see what is going on in the neighborhood. We are trying to expand and create a very wonderful environment for our students to be able to, and partners, to be able to do the work with ease. Before we begin the panel, I just want to request, the panel was supposed to start in probably around 10:15. We still have a few minutes. But that said, I just wanted to request that we have a short photo with the dean before he goes, because he told me he wants to go for teaching. And it is just an honor for us to have him around, just to have a group photo here as the panel prepares itself for the next session. We're going to have a technical session on mental health in refugees. And Dr. Sylvia and Dr. Justin Bukenya should be ready for us. So I'm kindly requesting that Professor and Mr. Tai, please come take the floor, and all of us join them. We take a photo. The gentleman, the lady Rita will take us a photo. And as a way of stretching a bit, I know we have just had breakfast, but it is important to relax a bit. Thank you. In a minute, I'll be grateful to see all of you. Thank you. No, you can't come up. You come and fill the space, because I'm told this is a very new space. It is not only for MCs and panelists. It is an opportunity for all of us to enjoy. Just in case you are not able to join us, I can help you climb. Yes, thank you. Yes. So for those of you that might be interested in knowing more about this auditorium, it is able to seat 502 people. And we are planning on expanding and adding several things in it. In case you see something that is not palatable, please feel free to give us feedback. But it is one of the places that is hoped to be hosting our seminars, PhD defenses, and several others. So you are most welcome to become a student in the future. And perhaps if you are one, this is one of the powerful spaces. Yes, you can also join down. In case you are behind me, you can also come down here so that they see you very well. I don't want to appear like I have been bribed to block you in the picture. Thank you. Is that fine, Rita? Thank you. Since we are all in the refugee area, it is important to show that even if the funding has been cut, at least we show a smile, really. Yeah, thank you. Let me know when you are done. Banange, camera person, ayagala smile. Thank you. Great. Thank you so much. I think now we can resume with our conversation. Yes. Thank you so much once again for the wonderful opportunity to have you here in our lens. As I I would like to know if Dr. Sylvia is in the building, and just in case she's not in, it is thank you, Council. Is Dr. Sylvia in? Just in case I haven't seen her, I'm going to quickly invite Dr. Just to Kenya, come through for us and lead our students present what they have so far prepared for us in issues mental health in refugees. Dr. Justin Bukenya is a senior lecturer in the Department of Community Health Sciences at the School of Public Health. You're most welcome. She's also a medical doctor, but also an advocate for adolescents and young people's health. Thank you so much, Doctor.
Hey, thank you, Davidson, for that great introduction. I think what you left out and seems to be very relevant to today's session is that I happen to be the academic coordinator for the Masters of Public Health in Disaster Management. Okay, so once again, it's a pleasure having you all. As I've been introduced, I'm Dr. Justin Kenya, and I'm going to moderate a session that is supposed to be for only 1 hour. We have 4 presentations. Can I invite the presenters to come up? We have Obo Fiona, Tulegalai Joshua, Musubika Sarah, and Juma Saida. You have 10 minutes to present your work so that we'll leave some 15-20 minutes for discussion. Can we have the presentation of Fiona up? In case you've forgotten your name, can the neighbor seated next to Bo Fiona kindly remind her she's needed up? Joshua, you are needed up. Sarah and Juma, we need you up here. Time, we've already lost a lot of time. Okay, right, so you have the mic. Go.
Protocol observed. Good morning, ladies and gentlemen. I'm Fiona Obo from Akere University School of Public Health, and I'm here to present my findings on perceptions, prevalence, and associated factors of depression among adolescents in refugee settlements of Ajumani district. Adolescence is a transitional period from childhood to adulthood, and it involves transformation in the physical and emotional well-being, which is very important for mental development. According to the World Health Organization, 7 adolescents that you meet, at least one of them is suffering from a mental disorder such as depression. And the World Health Organization also tells us that depression is most prevalent among the young population, and the 4th leading cause of illness, disability, and death among adolescents. Depression can happen to anyone, and in Uganda, 30.2% of the general population is affected by depression, and this rises sharply to 67.6% among refugees, making refugee adolescents face a double vulnerability due to the vulnerability, because one, not only are they facing the normal challenges that come with adolescence, but also stress that comes with trauma from displacement, loss of parents, and living in difficult conditions. Refugee adolescents in Adjumani district carry a higher burden of depression due to the experiences that they have. This is the trauma from the conflicts, and poor living conditions in the settlements that they live in. Research also shows that refugee adolescents carry a higher burden more than their non-refugee counterparts. Carry a higher burden, which is about 1.5 more times than the non-refugee peers. And in Adjumani district, studies have found that only 8% of these refugees who report mental health illnesses are able to access services. And this is not really good. This study seeks to assess prevalence of depression as well as its associated factors and perceptions of adolescents on depression in Adjumani district. My study objectives were to assess the prevalence of depression among adolescents in refugee settlements of Adjumani district, to identify associated factors with depression among adolescents, and also explore perceptions. And under perceptions, we also looked at barriers to to seeking care, and also contributing factors. This was a cross-sectional study that was carried out between May and June among adolescents aged 13 to 19 years old, and at least those who had stayed in these settlements for a minimum of 6 months. That prevalence of depression was assessed using the Primary Health Questionnaire 9, which is a tool that's used to assess depression. And also in-depth interviews were carried out to explore perceptions of these adolescents who were identified based on the cutoff point from the PHQ-9 of greater than or equal to 10. The overall prevalence was 57.2%, with most of the adolescents falling under having the moderate symptoms of depression. And under factors associated with depression, gender was associated with depression, with females being twice more likely to present with depression than males, and also adolescents who had lost either one or both parents were also twice more likely to suffer from depression. And then we also found out that adolescents living specifically in Nagojo were 4 times more likely to experience depression compared to those in Baratuku settlement. And then age was also associated with depression, with older adolescents, that is between the ages of 16 to 19, experiencing depression more than their young peers of 13 to 15 years. Then objective 3, which was about perceptions on depression. Adolescents perceive depression as a normal adolescent mood swing or spiritual problem that any other young person goes through. So it was more of a mood swing, and it was normal to them. So they didn't see any need of seeking help. So to them, depression is not a mental health condition. It's a normal thing. Then they also perceived depression as a mental confusion, where we had participants describing a state of being confused and unable to reason properly. And then they also perceived depression as a source of emotional pain, where a participant expressed not wishing not to have been born due to the suffering they were going through. And among contributing factors, adolescents identified trauma from conflicts and then poor living conditions in the settlements, such as overcrowding, scarcity of water, then also school dropout and early marriages, which reduced their chances of having, which increased their school dropout and early marriages, which increased their levels of experiencing depression. Then loss of parents, leaving them with lack of support, emotional support, poverty, limited access to mental health services, where we had participants not knowing what services were available and where to go to, and also prolonged displacement or duration in the settlements was also listed as a factor contributing to depression. Among barriers to seeking help, distance to health facilities was the biggest challenge. The available health facilities are really very far from their settlements, and also lack of information on available services, where they didn't know what services were available, what services were being offered, and also cultural beliefs, where depression was seen as something that was caused by maybe a curse or evil spirits. Financial constraints was also one of the major challenges that limited them from accessing health facilities. They were not able to get transportation because it's really quite expensive. A border to some to some health facilities costs about to and from costs about 8,000. And then stigma and fear of being gossiped about. Then coping strategies, adolescents mentioned engaging in small income generating activities like stone quarrying. Then also some chose to confide in close family members or friends. And then since they attributed depression to spiritual problems, some sought prayers, and then few resorted to substance use. In comparison to other studies, this study reported a high prevalence of depression among adolescents, which is higher than a prevalence that was reported in Nachi Valley refugee settlement, but notably higher than prevalence reported among Congolese refugees in Rwanda. Then on perceptions, these findings are consistent with other studies done in Uganda, where adolescents attributed depression to supernatural causes other than a mental health disorder. Other than seeing it as a mental health disorder. Conclusion, 57% of refugee adolescents, which was half of my sample size, showed signs of depression. And then also, when you look at the perceptions, it shows that depression is really not well understood in these communities, and therefore there is an urgent need for coming up with adolescent-friendly mental health interventions in these settlements. Then recommendations could consider educating adolescents, caregivers, and community members about depression. This could help reduce stigma and promote health-seeking behavior. Then also strengthen capacity by training more health workers, also involving teachers in schools, community leaders, since these are the first people to identify change in behavior. So they would help us if we equip them with these skills, they would help us identify and also support these adolescents. Then also integrating mental health services into primary health care. We all know mental health services are more concentrated in the urban centers and largely provided by NGOs, though on a small scale. So integrating mental health care into primary health care will improve on this opportunity, whereby every clinic visit is an opportunity to screen and support an adolescent. Fostering collaboration among the government, NGOs, and other humanitarian actors. No organization can address mental health on its own, so coming together as one would help us share expertise and also help coordinate efforts to avoid duplication of services, thereby improving on the mental health services, the settlements. Then also increase funding. In Uganda, only 1% of the budget is allocated to mental health. So if maybe you could reconsider allocating at least 5% of the budget, the health budget, to mental health, this could really help a lot. I'd like to acknowledge Makerere University School of Public Health, Basque Country, Farmamundi, the refugees and host communities in Adjumani District, Africa Humanitarian Action and the MESCO Development Foundation, Office of the Prime Minister, both in Kampala and Adjumani District, the settlement commandants, the District Health Office of Adjumani, yes, and my supervisors. Thank you for listening.
Okay, thank you very much. This was very informative. In interest of time, can we have Tulengera Joshua to share your presentation? You have 10 minutes. You can use 8. That would be great.
Good morning, everybody. Protocol observed. My name is Tulengera Joshua, and I'm from School of Public Health. Yes, I request that you project the presentation. Yes, my study was about assessment of prevalence, associated factors, and social support systems for PTSD among adult refugees in Chaka 2 refugee settlement. Yes, that's the author and the co-authors, Dr. Christine Narada, Dr. Catherine Obo, Ms. Juliana Namutundu. When we look at the introduction and the background, you see that PTSD affects 10 to 40% of refugees globally, and that is quite a very high number. Uganda hosts about 1.9 million refugees. Chaka itself has 118,000, mainly from DRC, South Sudan, and Rwanda. Rwanda is also there. Refugees face multiple traumas because they are displaced. First of all, PTSD is a mental health situation that comes about when you go through a traumatic experience. And it has some associated factors that influence it. And those associated factors are what I studied in Chaka. The problem statement, PTSD prevalence and associated factors in Chaka 2 are very underexplained. For example, there are so many projects that are handling different mental health disorders in Chaka, but PTSD is very underscored. The social support systems are there, but the documents that speak about them are very little. For example, I went to the Makerere University library and I was looking for documents on PTSD, and I assure you there were not less than 3. And the lack of data hinders effective intervention. My main objective was to assess PTSD prevalence, the associated factors and the social support systems in Chaka 2. Yes, I determined the prevalence, which was the severity of PTSD in Chaka. I identified the individual level factors, the community level factors, and also explored the availability and utilization of the social support systems. Are people using the things that have been put there as psychological first aid. The methodology, I used a cross-sectional mixed method study, given that I was handling both the quantitative and the qualitative. The sample size was 384. The tool, it was the PTSD checklist. It is a standard tool. It's called the PCL5. I had the KIIs, those are the key individual interviews, and the IDIs. The analysis, the quantitative, I used the chi-square and the Poisson regression qualitative. Then the qualitative, the thematic analysis. I wish I could explain everything to you technically. So I'm going to be graphic when it comes to results. The PTSD prevalence among adult refugees, you realize that it is 62%, and that is a very alarming number. That means that literally in every 4 refugees that you're going to find in Chaka randomly, 3 are going to have PTSD. And you realize that 38% is they're the ones that are not diagnosed with PTSD. Yes, when we look at the gender distribution, females were more responsive, the males refused. I don't know if it's because of the funding and everything that is going on in the refugee camp, because women were more welcoming as far as the study was concerned compared to the male. Yes, then we have the age distribution groups. I had the people that participated most were those between 18 to 24. The ones then followed by the ones between 25 to 34, 35 to 44, and realized the ones that are 35 to 44 were just not in the mood to answer the questions. And the ones between 45 to 54, they tried, but they were also not very, very welcoming as far as the survey was concerned. The education levels, I realized that most of my respondents were in primary level, stopped in primary level. Actually, they stopped in primary level because these are adults. Secondary, I had very few, and that takes you back to the gender distribution graph, where you realize that most of the people that answered this survey were women. And given the fact that they are women, it explains the education. I do not want to sound stereotypical, but on average, women are understudied in situations like Chaka compared to the men. The trauma exposure, we have death. I don't know why it's not showing there. It's death of a family member, war-related violence, sexual violence, and displacement. Now, displacement is a primal consequence to refugees. For example, someone moves from their country and they come to Uganda. They're going to be displaced, and that is a major trauma, because now people have made friends, they have their food, their culture, and they're moving to a different place. So it's scored highly. We have the war-related violence where people are tortured, everything related to the war. Then it was followed by death of family members, because most of them really said they lost family members. Sexual violence, I realized that most women that I interviewed, most of them have had a bit of sexual violence. Some is mild, some it's very, very profound, and I don't know why it did not overscore as far as the analysis was concerned, but that was its score as far as the analysis was done. Then I did not do barriers, but I felt it wise to look at the barriers too. We had stigma, financial constraints, lack of awareness, fragmented families, and language mismatch. I'm sorry for the encounter. I don't know what has happened, but it was fine. For fragmented families, these are families whereby the father has PTSD, the children have PTSD, the eldest sister has PTSD, and you realize that when most of the people, when a family is wounded, no one is there to help one another. So you realize that people do not run to the father because the father is also suffering from PTSD, the eldest daughter is suffering from PTSD. Literally everybody in the family is wounded. Then we had language mismatch. No, it was stigma. I made a pilot survey to a certain organization, I'm not going to mention, and I sat there for a week. And I tell you, the number of refugees that were coming there, direct walk-ins, it was very alarming, because from Monday to Wednesday, I only saw one person. From Thursday to Friday, I saw 2 more people. So we realized that people have stigma as far as seeking mental health services is concerned because they believe they'll be perceived as mad people. Then there was a language mismatch. When people do not communicate, no one can help one another. We had financial constraints. People do not want to invest money to go and treat sadness or to treat trauma. So that is very explained. But then lack of awareness. People do not know that they are even sick. They do not know that they have PTSD. So how will they go for the treatment? Yes, the discussion, there was high prevalence of PTSD, which is 62%. That underscores urgent need for mental health interventions as far as Chaka 2 is concerned. There was no significant quantitative predictors. Why? Because most of them were overlapping themselves. Someone has been sexually violated. Someone has lost a relative. They have had war violence. Literally everything is there, and when they overlap, you realize that they end up not being significant because at least they have bits of everything, which brings out that result. The qualitative findings highlight central role of family, yes, the peers and the religion in coping. Yes, NGO support valuable but not fragmented, not always inclusive. NGO support is there. Yes, I've told you it's there, but I've told you I sat there and no one was willing to come because of the stigma. Now, for the family, it's the most accessible, but you realize that most of the people in the family have fragmented themselves. The peers, people fear telling on others. Religion is the most effective, I would say. The spiritual leaders, the reverends and everything, they're doing the work, honestly. They are trying to consolidate peace among people, doing this and that, and religion scored highly. Yeah, I've explained the barriers to you. A comparison with previous studies aligned with global trends showing social support is critical in refugee settings. So many of you may not understand what social support is. Social support is psychological first aid in combating PTSD. And social support is I would call it the lay help that you give someone before they go to the hospital, like first aid, then you go to the main hospital. In conclusion, PTSD was high. Informal support systems are vital. That is the family, peers, and religion before they go for the NGO help. Then recommendation, strengthen community-based support. And I've talked about the community-based support, but before you strengthen, you have to teach the people how to be there for one another as far as PTSD is concerned. Integrate mental health into refugee services. Let it sink in that people that seek mental health are not sick of the mind. They just need help to be better because literally everybody has mental health issues. Address stigma and financial barriers. Yes, because now if people are not aware, they are going to start talking about things. Rumors are going to be there that people that go to that specific organization are sick. The financial barriers, I don't know. Organizations should put in more money as far as teaching people about mental health and taking them for referral for further help. Sustain NGO engagement, yes. Now, there is need to sustain NGO engagement. For example, I have a colleague that I talked to in Chaka, and if I myself can handle 384 refugees, assess them, and do all those things. I do not know why the most projects in the refugee settlements have 39 people, because I asked him, how many people do you diagnose and follow up and treat? He told me 39. So I really felt that that number is limited. I don't know if it's because of the funds and some of the projects where people are suffering from mental health disorders like PTSD, epilepsy. Some projects were scrapped off, and you realize where are those people going to end up. So please, there should be, the NGO should sustain engagement. Conduct further longitudinal studies. Why do I say that? Because you realize that this short study that I did does not really bring out the real predictors, the traumas. That is why we even reported non-significant results. It is because the study was short. And in case there is more money to do all this, we can go and find out what the real issue, the real associated factors as far as PTSD is concerned. Yes, thank you so much. Special thanks to Makerere University, African Humanitarian Action, Farmamundi, Basque Country Community Leaders NGO, and Refugee, participants, EMESCO, my supervisor, Dr. Naroda Kayemba, Dr. Catherine Obo, Ms. Juliana Namutundu. Thank you so much. My name is Kulengera Joshua.
Hey, thank you very much, Joshua. Another round of applause for Joshua as we welcome Madam Musubika Sarah to share her findings. Sarah, if you can use less than 10 minutes, that would be great.
Good morning. Okay. Perfect. My name is Sarah Musubika, and my supervisors were Prof. Eliseo Sutebembera and Ms. Juliana Namutundu. My study was on prevalence of depression, associated factors, and uptake, barriers and facilitators of uptake of depression healthcare among adolescent refugees in Kampala. All right, sorry about that. So adolescence is a critical time of growth for these individuals. It's a stage where they're growing emotionally, psychologically, physically, and all these changes of development are marked with vulnerability to mental health disorders. And among these, depression stands out as the most prevalent and most disabling globally. And it's even higher among those that are facing adversity, for example, the refugees that are affected by issues like displacement, instability. So Uganda is actually Africa's largest and the world's third largest refugee host, currently hosting about 1.9 million refugees, and adolescents account for more than 30% of those. And so in sub-Saharan Africa, the prevalence of depressive disorders is about 26.9, which is quite high. And a study found that refugee adolescents are actually 2 to 3 times more likely to experience depressive symptoms and linked to issues such as trauma, the disrupted social networks, to mention but a few. And despite this known vulnerability, it's something we already know, the mental health services remain limited and underfunded, especially in countries like Uganda, where many of these refugees reside. So from literature, we know various factors contribute to this. We know biologically, it could be family history of mental illness, it could be malnutrition, which these people are exposed to due to the issues surrounding becoming a refugee. We have psychological factors such as being exposed to war and violence, grief, family separation, and in all this, they use different coping mechanisms. There are those that use maladaptive ones, such as substance abuse, but there are those that use better options, such as, leaning on family and religious, their religions that they believe in. Even in their social environments, there are issues like poverty, breakdown of their traditional support systems, to mention but a few. So, despite the high rates, especially due to the cumulative trauma from all these things that they go through, in contexts like Kampala, there are still issues like stigma and limited awareness, as we will see ahead. And also the mental health systems lack the capacity and integration needed to effectively serve these adolescents. Yes, we know a lot is being done, but a lot more still needs to be done. So the objectives of this study was to look at the prevalence, look at the factors associated with depression among this group, and also look at the barriers and facilitators of uptake of depression healthcare for adolescent refugees in Kampala. We want to see, for those that are depressed, are they seeking care? Yes or no, and why not? So this study was a mixed method study that had a quantitative bit and a qualitative bit. The quantitative phase was cross-sectional design, where we looked at those that had lived in Kampala for at least 6 months, and depression was measured using a PHQ-9, using a score of greater than or equal to 10 to indicate depression for this study. And then using a sequential explanatory design, like following the ones that we found with depression in the quantitative phase, we then did a qualitative study using in-depth interviews and talked to them to see what are the barriers and facilitators that are affecting their uptake of health care. So the depression prevalence was relatively low, as we can see, with 3.9. It's broken down there because it covered moderate, moderately severe, and severe, while the mild depression was 14%. And then for the factors associated, the ones that really stood out were trauma exposure and length of stay in Uganda as refugees. So the adolescents that had gone through traumatic experiences, because we also asked about trauma, and those that had gone through traumatic experiences were found to be more likely to be depressed in comparison to those who had not. And then the longer, and then to go to the length of stay, the longer, those that had stayed in Uganda longer were more likely to experience depression, which could indicate the accumulative impact of prolonged displacement, like over time, So basically, this meant for every month they remain in Uganda, their likelihood of being depressed increases by about 1.8%. And then for uptake of depression healthcare, some of the barriers were stigma and shame. The stigma came in two forms. There's the external stigma, where people are actually stigmatizing you. But there's also that internal stigma that you get from, your beliefs. I mean, some of them believe it's like being weak, So then they're not able to speak up and seek care. Some of them, it was due to limited awareness of depression as a condition. One of them said, well, if I feel like this, and they actually did have the symptoms, but he said, when you feel like this, it's just being sad. You learn to live with it. I don't think it's something you need to go to the hospital for. So you see, they don't even really know that they need to seek care. And then family discouragement, Some lacked trust in health workers, and then due to poverty and logistical challenges, one of them shared and said, money is low, I can't ask for transport to go to African Humanitarian Action, yet there's no food at home, which is, understandable. And then, of course, psychological factors, fear, hopelessness. And then for the facilitators, those that had support from family and peers and encouragement were more likely to take up care. And then in the places where there's youth-friendly and confidential services, that was also a facilitator for them to take up care. And then, of course, availability of services from NGOs, religious institutions and schools. They said if that's where the services are, we can go and get them. So the prevalence was relatively low, likely due to more favorable urban conditions like better health care, NGO support and economic opportunities, and also youth-friendly mental health services were found to support early coping and help seeking, because as they said, if the services are like this, we will seek. So that is something that came up. And then trauma exposure and prolonged displacement were consistent with research showing that cumulative trauma, because it's before the displacement, during, on their journey, and even after migration, still affects them despite the stable settlement they got in Uganda. And and also it shows that this distress may not lessen over time. Then for the barriers and facilitators, we saw that family and community dynamics actually had a dual role. They, in some cases, there were barriers, where they're not supporting these people to take up health care, but then in other cases, where these adolescents had family that was supportive, they were facilitators for uptake of health care. And then stigma, like we talked about, and it's often rooted in culture and spiritual beliefs, where they feel, this is the kind of problem that is solved from church or from the mosque, and discourages them from, seeking care, medical care. And then socioeconomic challenges, as we talked about. And then peer influence was a key factor, because many of them said that if my friend goes, even me, I'll go, And so all in all, schools, NGOs, and community-based services were viewed as the most approachable, with a preference for age-appropriate, tailored services tailored to their social and developmental needs. So in conclusion, there's a need to increase awareness. At least these people need to know, to understand what they are suffering from, and also there's a need to reduce stigma. So, because even if they know, but there's still stigma surrounding the issue, they are not going to seek care. So there's a need to use outreach programs to provide psychoeducation to them and to their families, to their communities, so that this can promote help seeking. And then strengthening youth-friendly mental services through training staff in trauma-informed care for these adolescents, and ensuring that these services are confidential, culturally sensitive, and then leveraging community support. Because this, first of all, these are the people that they are with, the religious leaders, the elders in their communities, and their peers. So if we can leverage that support, maybe bring the services to a youth church, something, where they'll find them and this is already a safe space for them. So that is one way. And then also addressing structural and logistical barriers. For example, integrating it into the schools and community centers. This eliminates or subsidizes service costs, such as the person who talked about transport. Now the services have come to them. Yes, and of course, a sustained investment in adolescent mental health to break this cycle of trauma and build resilience. Because much as the prevalence was not that high, we saw there was also a 14% in mild depression that can easily become severe if not tackled early, if not given the support they need to improve. Thank you so much for listening. Those are the people I'd like to acknowledge.
Thank you very much. Realize we are having a good mix from settlement, sub-country, even urban setting. What a mix. So let us have Mr. Juma Said sharing his findings. Juma, you are carrying many gadgets. Hey, if you can make presentation within 8 minutes, that would be great.
Okay. Okay. Good morning. My name is Juma Saidi Tusuvira, and when I started this study, I was a student of Master of Public Health Disaster Management, and I'm one of the freshest graduates of this university. In the last ADF4, okay, I don't know, may need help, use one of your help. Thank you. Okay, I'll wait for them to project. So, thank you. In the last ADF war, the rebels ransacked Kasese town, and a polite soldier came to tell my family how to prepare to be displaced people. They told my mother to bring out the largest of the blankets and to only carry the essentials because it was a time of war and displacement. Maybe today I would be one of the 1.9 million displaced people in Uganda, or maybe in Congo, somewhere. Let me tell you, more than 60% of the refugees we have in Uganda are children. More than half of the refugee households that we have in Uganda have someone with a disability. We also know that being a refugee with a disability is a double disadvantage. In West Nile, 72% of refugee, over 75% of refugee households with someone with a disability are in poverty. And when we talk about refugee households that have children with special health care needs, we are talking about households with overlapping vulnerabilities. Let me explain what I mean. Already being a refugee is a burden. Having a disability is also what? A burden. Now, as if that is not enough, you have a child with a special health care need. These are children who have needs that go beyond what the other children need. We are talking about some complex health conditions. And then caregiving. So refugee caregivers have these overlapping burdens. So we set out to examine and document the experiences, challenges, and the coping strategies of these refugee caretakers. And we needed a methodology that could help us give a voice to this vulnerable population. And Photo Voice combines photography and social action. In this methodology, we empower participants to take photographs of their lived experiences and then use these photographs to facilitate dialogue of their condition and situation. This methodology gives a voice to the voiceless. So we selected 14 participants from the about 5 zones of Rhino Camp. We had a training workshop that covered research ethics, photography. Some of our participants had never touched a smartphone, and now they were going to use it to do a photography exercise in the community for over 3 months. And then every 2 months, twice every month, every 2 weeks, would meet and they present the photos of their choice. And then they explain what these photos mean to them. And even other participants would weigh in if they had similar experiences with that of the person discussing the photographs. And as a researcher, we were observing, and these discussions were audio recorded, which we transcribed and analyzed in the same way we analyze our qualitative data. So, what were the results? The result, we found that the refugee caregivers had a high burden of care. They reported exhaustion, that sleeplessness, stress, managing complex health conditions. Imagine managing cerebral palsy, paralysis, deep down in Omogo 6 in Rhino Camp, refugee settlement, where you are off-grid of everything. Structural barriers, food ration cuts emerged as one of the biggest factors that were stressing people. People were crying about something called Category 3, where you used to get food, but now you are considered a bit able-bodied by face value. But it's because that the aid is little, so that you have to be taken off the food aid. Unaffordable treatment. Some were referred to Arua regional referral. With no money, resources for referral, some things there have to be paid out of pocket. Referral systems were weak, and they had limited access to care. In the community itself, children were abused, they were mocked and isolated. And even the parents themselves were being discriminated against. And in some instances, there was minimal community support. However, we found that amidst all this, the caregivers demonstrated resilience and strong coping strategies. For example, they shared caregiving roles between men and women, saving groups, prayer, they had adoptive parenting. They were also advocating for counseling services, gender equity, and better health services. A snapshot of some of the discussions. So the lady who took, the participant who took this picture, told us that this is her compound, and this is the house I'm sleeping in. The one carrying the girl was me. This girl was 12 years old. I have a 4-year-old who already weighs 10 kilograms. So this is a 12-year-old. You can imagine. So she has to take her out every morning. She cannot go anywhere to fend, to do anything for herself. And this is the burden that they expressed. This participant told us, and that's a direct quote from what she said, "We are seated with my daughter who is having the lame leg. I'm now thinking, what am I going to do to that daughter of mine? I'm thinking a lot. This is why I'm seated like that. I was seated quietly with no talking because my mind is thinking of all that I'm going to do." So this participant was telling us that their child wants to move to them, but they can't, and they get frustrated. The wheelchair is veering off the way, and they have a lot of pain, and this is all on the parent who is watching. So this participant was referred to Arua, and they do not have the money to buy the medicines that were prescribed in the referral facility. And she concludes by saying, the boy will suffer a lot now because of eye problem, and he feels badly. So this is one of the refugee caregivers who has a group supporting other caregivers by teaching them skills such as plaiting hair so they can have an income. This is one of the participants and is talking about diversifying the diet, adding vegetables and greens. And he's also advocating and encouraging other caregivers to support, to give these children all the support they can. And they should not discriminate that this work belongs to a man and this work belongs to a woman, but they should come together for the good of the children. What do we recommend from these findings? Number one, we should integrate disability responsive care in health, education, and other social protection programs for refugees. We need to protect vulnerable households from food ration cuts and improve referral pathways to specialized health care. Colleagues, food aid is the bloodline of refugees who are vulnerable. We also need to provide support to these caregivers by giving them counseling, psychosocial support, and also doing anti-stigma campaigns to reduce issues of isolation and discrimination. So, in conclusion, caregivers have intersecting challenges, and humanitarian programs should prioritize inclusive health systems, sustainable food security, and psychosocial support to strengthen these caregivers who are already carrying a heavy burden. So, this study was funded by the Royal Society of Tropical Medicine and Health. And as I conclude, we did a local dissemination where the participants displayed the photographs from the study. And we had several stakeholders that came to see these photographs. Before I started the study, I promised them that I'm going to train you and help you to tell your story to the world through photography and research. And they told their story that day. And today I continue that story with one key message. In Juba Arabic, Wehida Yahugua, unity is power. Thank you.
Thank you very much, Mr. Juma. I thought you were going to take photos here so that at the end of the day, people have stories also to share when they get back home. I think we've had a good mix. You agree with me? We started with Fiona, who really told us that whenever you see 3 adolescents in Germany, in the refugee setting of Germany, 2 of them have got symptoms that confirm that they have depressive challenges. So, Fiona, as I make my remarks and inviting people to make a few questions and suggestions, be careful. Whenever we use that tool, we are not good enough to confirm that we are talking to signs. The signs are confirmed by clinicians. So whatever you met were symptoms, and maybe it is probable depression. The same applies to Sarah. You don't have the mandate to say that those people had a depression or not, but they have symptoms that speak to depression. Let us be careful when we are making these presentations, and more so if you are going to publish our work, which I would urge you to do so. The PTS from Joshua, this is really interesting, and it's not surprising that we have very few men who participated. Everywhere we go, maybe here, this is something very unique where I see more men than women, but wherever we are, we have more women participating. Yet, men are more likely to have more of these symptoms than women, because women have better coping strategies, as you've seen. They have groups, they are very prayerful, so all these make them survive a little better. But we need to make sure that all our interventions really speak to both women and men. Sarah, in Kampala, it's really surprising that we have only less than 4% of people with the symptoms that speak to depression. What could have gone wrong? How sure are you that what we are seeing is what is on the ground? Apart from these refugees being in Kampala, I would expect even people who are not refugees, the young people, the way I talk to them, many of them really show symptoms. But now if they are refugees and we only have less than 4%, I would invite you to review most of the literature that speak to depressive symptoms among adolescents outside the refugee setting, and you compare your results and see maybe there was something. What I realized that we really face as a challenge when it comes to mental health is the definition. So many of us, our mental health literacy is really below expected levels. We do not know what mental health literacy is. And where we've tried to do some assessment, there is a study we did comprising like 9 countries all over Africa, but the definition is really lacking. And when it comes to translation, one time we did it in the eastern part of Uganda, the translation was very challenging. I don't know, maybe when you're responding to some questions, you share with us your experience when it comes to translating this word depression or the symptoms that speak to depression, how easy it is for you to make this translation, and also make sure that the people you are interviewing really you are on the same level. Translating mental terminologies, even where we've worked with experts, it is really a challenge. So this confirms that mental health literacy is still a big challenge moving forward. The caregivers shared by Juma, It's really saddening, you know. You're already a refugee, you have a child, or you're taking care of somebody who has a disability. The systems are not very supportive. You are there on your own. I really agree with your submission at the end of the day that we need to do a little more to have systems that really cater for people with a disability. Otherwise, the caretakers are going to experience the burnout syndrome. So we are remaining with a few minutes, 10 to 12. I invite people with questions, be specific to the presenter. You want the question to be answered. All right, kindly introduce yourself because we do not have a session for introduction. All right, thank you.
Yes, thank you, moderator. I'm Dr. Drameto Dominic from Germany, the DHO. Germany is host to the largest number of refugees. We host 234,000 refugees. To Fiona, yes, I want to thank all the presenters. One thing I want to agree with is, yes, you said the access to mental health services is very low at 8%. That could be true because the current structure of local governments is that if you have a district hospital, you have 7 health workers there, and then only 3 in the health center, 4. We used to have partner staff, but now they are no longer there. So probably this low access is true. But your prevalence is a bit high for depression. You will explain a bit. Because we did a study in 2023, where using facility records, the prevalence of depression was found to be at 33%. Maybe it has increased. So probably you will educate us more on that. One thing we need to do to combat this low access is integration of services, like they rightly said. But right now, we need these health workers to be mentored. In Germany, we have adolescent-friendly spaces at all facilities, but we don't have the healthcare providers. So we need to ensure we mentor. It is a health worker, if not all, to be able to detect and manage the simple ones and refer. But also we need to go to the community. The VSTs also need to be educated so that they should be able to detect early and refer. Otherwise, I think all your results point to one thing, that access to services for people who are mentally disturbed is very low, and something needs to be done about it. Thank you.
Thank you very much. Any other question?
Thank you very much. The presenters on this issue of mental health. Your results are very good to inform systems, more especially when it comes to the primary healthcare system. The truth of the matter is, one of you mentioned that primary care, mental health is not in a primary healthcare system. What I want to inform us is that it is there. The issue that we have is that probably the attention of the health workers to most of these areas, more especially mental health, is where we are having challenges. And we have always thought that we need to handle these things separately, yet the resources are dwindling in every area. This calls for the song of integration of primary health care services where mental health is supposed to be or is supposed to be. So integration at the moment is the game changer in the healthcare system, to making sure that most of the services, primary healthcare services especially, are all handled in a one-stop center. When you get to a facility, for example, and you enter OPD, mental health should be screened just like any other services, to ensuring that these prevalence are brought down. Specifically, you talked about the distance. In the healthcare, in the Ministry of Health is trying its best to making sure that the aspiration of having health center 3 per sub-county comes to pass. But at the end of the day, when you look at these settlements, more so in Ajumani and any other refugee hosting districts, you realize that most of these settlements are far, probably in the areas where they used to be like desolates. They are far from the closer areas. And yet when we are planning construction of health facilities, we put so many considerations where the people, the host populations are. If we put a facility in the settlement specifically to address the refugees, what about tomorrow when the refugees maybe go back? So it's a consideration of having host community is a key factor when it comes to establishment of a health facility. So the aspect of distance, I know, and because maybe I may introduce myself, I am the person who has in charge of refugee health services in the Ministry of Health. So we have always had these challenges in the issue when it comes to aspects of the distance from the refugee settlement where they find the healthcare services. But this is because when establishing these facilities, we consider that aspect of where the host populations are, so that we can establish a facility which will support both the refugee host population and the refugees themselves. So this is a kind of an administrative and policy issue. But I know once the structures and the systems are put in place and the services are there, we may not feel the issue of distance so much, but at least if the services are found in those facilities is what we would concentrate on, as in my opinion. Otherwise, I thank you for that point coming out from your studies. Maybe we can go on the discussion later on.
Hello, my name is Begoña and I work for Farmamundi. Thank you all for your studies and your presentations. I was wondering, so this is a question, I'm sorry, for all of you. I have had the chance to visit Kampala and also Chaka. Unfortunately, I have not been to Rhino or Adjumani, but I do think that maybe there are specific opportunities linked to the contexts. So rural, urban, that was mentioned in the case of Kampala, and I wanted to know if you have identified or you have any ideas of opportunities for this community-based mental health tackling within the different contexts that you have been studying and analyzing. Thank you.
Two more comments, then I will request presenters respond to those.
Thank you very much for the amazing presentations. My name is Oscar Taremwa. I work with Strong Minds Uganda as a partnership coordinator. And I really listened with deep interest in that we are in the mental health space. At Strong Minds, we focus on scaling community-based mental health care, particularly through groups, interpersonal therapy. So hearing these findings really marks much relevance of the work that we do. So I have insights for each. One is Abo. Your study on adolescent refugees in Adjumani highlighted very high prevalence of depression and how stigma and access to barriers continue to silence many young people. I'm curious from your experience, what community entry points or engagements strategies seemed more feasible for you in building trust in these adolescents? That's something that we think a lot about during programming, and I think it can be of interest to us if you can share with us. Then Joshua, your findings on PTSD and the role of social and religious support networks were powerful. It made me think about how partnerships could better leverage those community structures, like churches, youth groups, even refugee leadership, to strengthen early detection and referral pathways. So if you could just briefly tell us about how that came up and how you managed to trickle that, then it could also be of help. Then I will end with Sarah, just appreciating the focus on urban adolescents and the barriers they face in seeking care. Still at Strong Minds, we're expanding work in urban spaces also, as well as urban refugees, working in partnership with AHA. So your findings on stigma and limited awareness really stand out. And how does the youth-friendly or peer-led intervention help bridge this gap according to your findings still? Thank you.
I'm Kyomuhendo Patrick. I work with the MS Co-Development Foundation in Kiaka. Thank you all the presenters for the wonderful presentations and informative presentations that you have given to us. Just mine goes to Joshua. Was your research you conducted this year or some time back? If it was this year, then the refugee population is underreported. So 118 is far below from what we have. We have over 135. Commandant will talk about that, I believe. But that is not in research that happens. Another thing is about that organization that you didn't mention, but you sat with them for almost a month, and they told you they could only receive 39 cases of people coming to seek for mental health services. You would have probably, I don't know, if there would have been another way to find out probably why. Why? Because 39, from what we know, there could be probably issues of relapse, that these people have been coming, reporting, seeking for health services from these very organizations, but the support probably has not been sufficient, and therefore they have given up. It's not that indeed they are not aware, or there is stigma, there is fear. No. Probably there could be underlying causes that are triggering or letting this to happen. Otherwise, thank you so much, Juma, for that photography storytelling. It is really emancipating. Thank you.
Yes, thank you very much. We can get the last.
Thank you very much. I think we have many questions, or points for discussion. I would invite the audience to write down your questions or comments. We can discuss this during lunchtime. It's really interesting. So in interest of time, let me invite the presenters in 1-2 minutes to respond to the questions where you are sure. In case you are not sure, you can refer them to some journals to read more about that. Your students, you are still building your capacity. So quickly, in 1-2 minutes, respond to the few questions that have been raised. Kindly pass on those questions. They will make our students, come out better presenters in the future.
Mr. DHO, to answer your question, why prevalence seems so high, I got an opportunity to talk to some of the mental health experts, and I was told in a month, they only receive about 5, 6 to 10 people, that's per month, which is really not okay based on the population you've given us, the total population. And then also, yes, there are services, but utilization of services is low, and then also the coverage is really low. And then also mistrust limits openness, so people prefer to keep quiet, struggle silently other than talking to people or seeking help. And then how did I build trust with the participants? Mr. I've forgotten your name, sorry about that, but I think you said you're from Strong Minds. I worked with community leaders and VHTs during the qualitative bit of the study. Hope that answers you.
Thank you for the feedback. Thank you. I realized I kept saying depression instead of depressive symptoms. I will improve that. Then you asked, translating the word depression, how that was. We realized that actually it ended up being, we were there to collect data, but also ended up having to teach a little bit, because it wouldn't make sense to just ask the questions when you realize they don't understand, because we asked and some, gave these definitions of depression that are really not. So we tried as best as we could using symptoms to try and explain to them what it is we are talking about before collecting data so that they can understand. Yes, you asked about ideas for Kampala, for the urban. I think I now realize that awareness is still much needed. I don't know, I assumed that with all this talk about mental health that it had reached everywhere, but I now realize that there's still need for education, to actually educate the people themselves, the people we've gone to interview to participate in our studies, but also the health workers to have a better understanding, and also the communities, the parents, and even the religious leaders, because some of these people actually run to their faith as their safe space. But it would be a good thing if they also knew, if they were also able to recognize that, okay, I am encouraging this person, I'm counseling them, but they are at a point where they need medical care. Let me say, they say, oh, they open up about suicide or things like that. So I think that is a much needed thing, because it helps, first of all, people to be able to recognize that they need care. Yeah, I think that is, yeah, that would be really important in my opinion. And then the gentleman from Strong Minds asked how youth-friendly services help with stigma and limited awareness. I believe if the mental health is talked about in these safe spaces, because adolescents are interesting individuals. They can refuse to open up, they can refuse to hear what you're saying. So while Strong Minds and all these other organizations, as you create these safe spaces that are youth-friendly, that would be an opportunity to tackle this limited awareness in your ways, to bring up mental illness, and also to bring up stigma. Yeah, I think that would be a way to merge that, so that the information on mental health and mental health care is out there, but also that they are able to understand that it is not their fault. They need care and they are allowed to have it. Yes.
Yes, thank you so much, Sarah. Thank you, Doctor. First of all, I would like to thank you for informing a major intervention that I did not talk about, or a recommendation. Doctor told us that the males, I talked about the female participating more, and so this goes out to the policy makers and the people that are in charge of that, to see that more males take part in studies like mental health, because they do not have coping mechanisms, good coping mechanisms as the females do. Thank you so much, Doctor. Then when we go to the gentleman from MESCO, the one from Chaka, thank you so much for the update in the number of refugees. I skipped that. Then when about the organization that I talked about, I said I was there for a week. And a week is not probable time to report on something, but it was just a mild observation that I made. It reported the stigma. I would say it spoke to my variables, like the stigma, the fragmented families, and most of those things. Yes, but it's not a general observation. It has not been studied. It is just a simple observation. Yes, thank you so much. Then from the gentleman from Strong Minds, you've asked about how the integration can be there between the organizations and the people offering the psychological first aid. Yes, I conducted IDIs with the religious leaders, the community-based leaders, and the NGOs themselves. The others were the individuals, which were the IDIs. So when it comes to, I'm going to talk about the religion. You've talked about religion. Yes, these people always have mass, I would call them mass sensitizations, where people that are seen as key people in society are taught on how to deliberate psychological first aid to the people. And the way they are doing that is they are not overly, the preacher said, people will come and report to them and tell them that I'm going through this. I was from when I was this side, I was sexually violated. I lost a brother. The religious leader is following ethics of confidentiality, and they are not just going to come and say, they're not going to go to the organization that is implementing mental health services until the person there that so and so and so and so told me that they are sick. No, they are just going to highlight an area. For example, there will be like people in Sweswe are going through a lot of PTSD. Whenever they come to church, they are telling us this and this. So the collaboration is really there, and the OPM and the implementing partners like AHA are doing the most to teach people that are key members of the community to help people with psychological first aid, because it grooms their health-seeking behavior, which is the professional help. Yes. I don't know if it makes sense, but thank you so much.
So thank you. Probably encourage more partners and researchers to use participatory methods, especially to bring out some of the issues that people may not be comfortable to bring out, especially in mental health. Thank you.
Thank you very much, our presenters this morning. Kindly join me to thank our presenters who have walked us from rural to urban,
Some good big
from
clap.
victims
Big
to
clap.
caregivers. It's really been wonderful. Thank you very much. We don't have a lot of time. We're supposed to have break for 15 minutes, but now time for break is over. So what we do, we get a health break for 5 minutes, and then after 5 minutes, let us catch up. Thank you very much for being an active audience. And during the break, kindly feel free to interact with our gurus here. Thank you.
Thank you, Dr. Justin. Lucia, before you go, I just wanted you to help us, lead us in a quick health break so that people can stretch a bit. Yes, yes. You can help us tell us a few things on how we can stretch. I've been told that you are close to people who like physical activity. Yes.
I am going to kill you. Actually, I'm a humanitarian expert, not a sport expert, and I need to check some Zoom things. So I think you can just like stretch legs, arms, everything, walk around, and you'll be fine for sure. Thank you.
Even that is fair enough. At least I wanted to see how you people smile. Thank you so much once again. I should like to say that if these people finish taking their photo, we should be on course to the next conversation. But I want to take the honor and pleasure to thank you, ladies and gentlemen, for being patient and coming through for this particular session. My colleague who has offered to be part of this engagement, Harry Moses Kabonge, is a colleague who likes to co-MC, but he doesn't like holding a microphone. But nonetheless, thank you so much. For the health break, I will just request that we just stand up a bit. Just stand a bit so that we see how we can, you know, when you sit a lot, this gentleman is going to guide us on what we are going to do. Do you want me to hold for you the mic? Of course, that means that I will not be in position to do what you will be demonstrating.
You have
Okay.
Yes, very simple. We're just going to spell the word coconut with our body, something very simple. Yes. Okay. Let's just, you know, coconut starts with C. So our C will be like, depends on which side. If you are from Spain, where does C face? I don't know. Yeah. Where does C face? Okay. C. O. C. O. And go down, come back. You. Now, it has to be done very fast. Yes. Because when you're writing, there are some people who have shorthand writings and they do very fast. And those who are slow. But this time around, I'm dictating. So let's do it very fast. 1, 2, 3, let's go. Okay, thank you very much.
Wonderful. Thank you so much, colleagues. There is a popular phrase in Kampala If you hear me use the word colleagues, just know I am trying to step in someone's footsteps. So colleagues, money will come. Thank you once again. I've been told that we are coming close to the next session, but I want to thank you, Dr. Justin, Abo, Joshua, Sarah, and Juma. It was a very heartwarming session, and I think you will agree with me that they did some fantastic job. If you don't mind, please give them a round of applause. Where is Juma? Is Juma in? Okay. Juma, I thought probably in the next time when you visit the camp, or perhaps the settlement, instead of telling us issues of Wehinda, Yahugua, that is unity is power, we would expect phrases like people and power. Thank you. I have been told it is, we're supposed to go to cross the borders and speak about the barriers that people face when you cross the borders. And we want to see how do we address, how do women in Spain access health services. And at this particular moment, allow me, as we transition from this session, to recognize that in the house, we have the wonderful people up there that are doing us a good job relaying these things. The person offering us a live stream, it is available on YouTube. You can share with colleagues who are interested in following. Mr. Eric Rubega is offering us the live stream. And so whenever you are speaking, feel free that and be sure that you have an international audience watching. So the link can be shared. I think Lucia and colleagues from AHA, you can share the link to the people in the room so that they can be able to follow through. Our next presentation takes us beyond Uganda's borders, looking at health access for women from Uganda and the region, especially living in Spain. I don't know if we have Miss Nuria. Lucia, are you the one going to handle this? Okay, so Lucia is the one who is going to give us these wonderful experiences and insights from crossing the borders and as well as facing the barriers. Oh, I have been told that she's already available online. Yes? Thank you so much for coming through. We are waiting for you, Miss Nuria Flores from Sidalia. You are most welcome. Thank you. The floor is yours.
Thank you. I think
are you able to hear us?
Started with yes, and do you listen
okay.
to me?
Sound, please.
Do you listen to me? I can hear you, but do you listen to me?
Okay,
Andrea?
as she comes, just be sure that
okay.
in case you are very
So
new.
you started, Andrea, and I am going to...
Okay, we can hear you now.
Okay, you're working on the sound. Okay. Okay. Okay, they can hear us well. Perfect. Let us know when we can begin.
You started, Andrea?
Can we begin? Okay. Good morning, everyone. Thank you for allowing us to be here with you today. My name is Andrea Arana, and I work in the Department of Education for Social Transformation here in the Basque Country in northern Spain. Today, we're here to present the results and key findings of a study we conducted on the access and barriers in health services experienced by women from Uganda and the surrounding region who reside here in the Basque Country. This study was developed as part of the education, awareness raising, and advocacy activities implemented within the framework of the 2023 Humanitarian Response Strategy, financed by the Basque Agency for Cooperation and Solidarity. Our education work aimed to raise awareness and understanding of the conflicts and crises of the regions where we carry out humanitarian activities. More specifically, we focus on sexual and gender-based violence in context of armed conflict, its causes, needs, and impacts on survivors, while also emphasizing that this type of violence is not limited to conflict settings, but also occurs in contexts of peace, including here in the Basque Country. This study is one of the outcomes of our education strategy, as it helps us to better understand the barriers to accessing healthcare faced by women from this region who are now living here. The key findings allow us to bring greater visibility and to raise awareness and advocate both with formal and informal institutions, with organizations working on health and migration, and with public administration regarding the barriers that migrant refugee women face here when trying to access health services in Basque Country. For this reason, we have partnered with Sedalia consultancy team, given their extensive experience working with African communities across Spain. With their support, we have been able to conduct the necessary interviews and analyze information gathered to identify the key barriers and recommendations for improvement. It is my pleasure to introduce Nuria Lores, the lead representative of Sedalia, who will present the main findings of this study. And at the end of this presentation, we will have some minutes for questions. Thank you all for your attention.
Thank you very much, Andrea. First of all, hello everybody from Madrid, Spain. I would like to thank you, Makerere School of Public Health, Farmamundi, Africa Humanitarian Action, MESCO, and especially the women and professionals who has participated in the interviews. So thank you very much for all of you. Research approaches for us are very important. The study applies a participatory approach, a gender and intersectionality lens, and a human rights-based approach. And also, we applied triangulation methodology across methods and perspectives to ensure both quality and depth in the finding. So this is the framework of the research. About the methodology, we use qualitative methods, mainly semi-structured interviews. We conducted 13 interviews with professionals and 19 with women from Uganda, Republic Democratic of Congo, Central African Republic, Angola, Somalia, Kenya, and Ethiopia. You can see here this frame. All the women interviewed live in the 3 provinces of Basque Country, but they came from these countries. Despite the framework in Spain, this population is statistically invisible, only around 1,000 in Basque Country, so it's very difficult to contact with them. This invisibility contributes to a lack of targeted policies and persistent structural and cultural barriers. So this is very important to mention because it's very, very difficult to find that population in the Basque Country. We the analysis identified 13 types of barriers, including legal status, language, localization, digital access, gender, mental health, racism, and a lack of knowledge among health staff regarding migration or specific conditions. The entire report is based on the testimonies of the people interviewed. Below, we will analyze each of these 13 barriers, presenting the testimonies in the first person. Here are the 4 barriers, and you can see in blue, these are verbatim extracted quotes, like the women said, because I think it's better to know in the first person the testimonies to show what they feel. About legal status, several women reported difficulties in accessing healthcare due irregular administrative status. As one participant said, registration has become a subject of speculation. About language competency, many women spoke little or no Spanish, Basque, or a little Spanish. The absence of interpreters and translated materials created confusions, errors in treatment, and feelings of exclusion. One woman shared is frustrating not to be able to communicate with the person who has the solution to your problem. System knowledge. Lack of information about how the system works creates barriers. I have not been clearly informed about the resources such as vaccination, preventive care, or social assistance, as one woman said. Lack of migratory knowledge among health professionals. Administrative staff and even doctors often lack understanding of migrants' legal situation, rights, and needs. This led to inconsistent treatment, misinformation, or outright denial of service. As one participant put it, healthcare professionals in training need to be taught about the healthcare realities in their countries of origin. They don't know how hard it can be. We need professionals with more empathy, who are not afraid to take action against some mutilation or violence. We continue about the next 3 barriers. Rural versus urban. Here also in Spain, there are a lot of difference between the cities and the outside. Interviews living in small towns described greater isolations and fewer services. For example, public transport, local health infrastructures, and so on. One noted having to catch the last bus or fix the car for transport as a barrier. Support networks and employment. Many women lack family nearby and work in precarious jobs. Without flexible hours or social support, attending appointments become difficult. As one participant said, I have been self-sufficient and a fighter, raising my family on my own, and security stable housing through hard work and contacts. Economic or financial resources are also a barrier. Job insecurity, as I mentioned, limits migrants' women to access to healthcare and their ability to pursue treatment or outside the public system, creating dependence on institutional assistance. Even if you are ill, you have to work. Otherwise, you won't eat or pay for housing. Okay, continue with digital accessibility. Many women were unfamiliar with online systems like Osakidecha, which is the name of the health public in Basque Country, or lacked digital literacy. Booking appointments, accessibility test results, or downloading vaccination certificates was overwhelming. One quote, I have limited digital access. I use my mobile phone a little. Cultural barriers. Interviewers expressed that the system does not recognize their beliefs or customs. Some felt misunderstood or even judged for their practices. They also don't understand the treatment prescriptions of the Basque Country healthcare system. Always paracetamol. We are tired of paracetamol. Here is very useful to use paracetamol in the public health in Spain. Gender barriers, many important these barriers, and women often prefer female providers, especially for reproductive or sexual health. Yet it's not always respected. Sometimes their partners make health decisions from them, which violates their rights. They were examining me, but they were talking to my partner. About mental health, as you mentioned, many women showed signs of trauma, depressions, or anxiety, but said mental health support was not offered. No one noticed my depression. I had 3 terrible years. They only gave me 5 minutes. About racism and discrimination, several women describe racist comments, stereotyping, or being ignored. They treat us as if we were invincible. Woman, black, young, so nothing can hurt you. About medical knowledge, professionals often lacked knowledge about conditions prevalent in sub-Saharan populations, like tropical disease and so on. And one respondent noted, healthcare professionals is training. need to be taught about the healthcare realities in the country of origin. They don't know how hard it can be. We need professionals with more empathy. To know, for example, in black skin disorders and so on. Okay, now we conclude the barriers, and the next two slides are about conclusions. Key findings for public authorities. We are presenting that in some other meetings with Farmamundi, because they are very important to try to change the things. And these are the key findings for public authorities. Although healthcare is legally universal, real access is unequal. Services lack translation, cultural mediation, and training on East African health is needed. Bureaucratic and digital barriers disproportionately affect these women. And also, this is little knowledge of training on conditions like trauma or mutilations, genital mutilation. Social organizations, the key findings are that woman delays seeking care due fear of bad experience. They demand personalized support, stronger community networks, and intercultural mediators. They also highlight the need for more anti-racism training and accessible health rights education. As with the main findings, the report sets out of a series of recommendations for the main key players. Let's take a look in the next slides. Okay, these are the main recommendations for public authorities. Key recommendations include remove administrative barriers, guarantee translation services and digital access, train staff on racism, trauma, and sexual and reproductive health, collect disaggregated data to monitoring equality, expand mental health services is also very, very important. And the key recommendations for social actors. The social actors are called to provide individual and collective accompaniment, train community mediators, develop digital and health literacy, foster leadership among migrant women, create safe channels to report racism, work for an intersectional perspective, and participate in policy making. It's very, very important, the word intersectional, institutional policy spaces. All the organizations we are presenting the report are agree with that recommendations. So thank you very much, and we hope these findings help inform inclusive policies and better practice. Thank you for your attention, and especially for the women who trusted us with their voices. Stop sharing. So if you have any question, Andrea and me are at your disposal.
Thank you, Nuria. Thank you, everyone. We're now open for any questions. Please, feel free.
The report is going to be sharing that presentation also, so you can do a bit more reading and know about all the conclusions and recommendations. A lot of silence. Also, we interview, I don't mention in my presentation, but also in the validation of the hypothesis, we interview the teams from Uganda and Kenya, and they help us to validate also the barriers at the beginning of the investigation. So thank you very much for that participation also.
Thank you. There is a question here.
Service. Looking at the fact that my mind is acculturation. So I'm wondering.
Sorry, we cannot hear it.
Yes, we cannot hear properly. Perhaps after with the micro, you can repeat.
With the microphone, yes, please.
Given the fact that these people are coming from Africa and going to Spain, how do they adopt to acculturation, and how does it affect them? Because now they have to deal with medical support and mental health issues, but we understand there are so many cultures within that country. Could it be that even acculturation is affecting their adaptability into that country, influencing the research results?
Thank you. I understand that the question is how they how do they adapt to culture and how that affects them, correct?
Thanks.
Thank you. And cultural things that affect the findings. Okay, thank you. Well, we know that integration is a gradual and long process where people will tend to um, adapt to the culture and also integrate to some of the practices, languages, and activities that people here perform on a daily basis. That does not mean, however, that they are supposed to forget their own cultural background, languages, and practices. Mainly, we find that some of the people here tend to learn the language first, Spanish, because there's two different languages here, Basque and Spanish. So firstly, they tend to start with some language classes through the support of several organizations, such as the Red Cross, or some support that the government provides here to some refugees. And that is the first step. That is the first step to being able to communicate with the society, and that also enables them through learning languages to get to know more people and to integrate to the society as a first daily basis. Regarding how that affects them in several ways. Firstly, to be able to find jobs, to be able to access to proper documentation, to try to understand how the system works here. Also being able to go to education, to health services, because the language, of course, is key to be able to communicate how they are feeling, to be able to understand whatever disease they are going through, and to be able to understand what type of medical support they will receive, as well as medication. So in this case, the Basque government does provide translating support to be able to support that health service. But it, of course, is a gradual and long process to be able to integrate and not being able to be affected by those barriers. Nuria, if you
Thank
want
you, Andrea. Yes, only to add that many of these people already have children in Spain. And in many cases, it is the children who act as natural mediators also, because they learn easy Spanish in school and so on. And sometimes they go with the mother, with the family, to the doctor, to the lawyer, to the police, to every place. And it's interesting to analyze the role of natural mediators about the children. It's also another investigation, but I propose to do that.
Hello?
Hello?
I have just two questions. One, is there some sort of social structure that has been created by the refugees that are living in Spain? Just like in Kampala, we are having refugees finding themselves living in one particular area basing on their country of origin or the tribe that they speak. So my question is, are there social structures being created by these refugees that are living in Spain, and are these structures giving some sort of functional support system for these refugees? And then two, from your study, I realized you interacted with a number of nationalities, some from Uganda, some from Spain, I think maybe some from other places. Are there specific differences that you found as far as your research question was concerned? Thank you.
Two questions. I would like to mention the team of the interviews are composed from 3 women, one from Angola, one from Cameroon, and one. And when they belongs to Fidalia, and when they have to found people from Uganda or the region, they have a lot of efforts to contact them, because as I mentioned, statistically, there are very, very few. So it's very difficult to contact them. There are also, as you mentioned, social structure for refugees, but they don't live in some place there across the Basque country. and they have some informal networks. There is also one or two associations, but it's very difficult to contact them. They don't have a structure, a social structure. And this, linking with the second question, as you mentioned, they are very, very different between that countries. But they share one thing. There are women and there are black women in Basque country. So we also interviewed some people that are adopted. They are Basque from nationality, but they are African from origin, and they have the same problems that the other people who came from Africa. So there are very differences, as you mentioned, but the most they share that there are women and black women in the Basque country. So they share the problematics and the stereotypes and the racism and the structural barriers and so on. I don't know if Andrea would like to add something.
Yes, I could mention an example of one of these communities. For example, here we have the Association of Basque Congolese Women. These are women coming from the Democratic Republic of Congo, and they have come together to find mutual points, or they can support each other and also advocate for their rights. As Nuria said, they also face, the majority of them, the same problems and barriers to accessing health services and to integrate into the society. However, they also invite other women from African backgrounds to join this association, and they hold weekly or monthly meetings to talk about their problems, to propose activities. For example, recently there was a huge protest, and they came out to the street to protest on the different sexual and gender-based crimes of the Democratic Republic of Congo. And a lot of the community came out to the streets, and they were supporting this protest publicly. So yes, they are various communities of African communities here in Euskadi, in the Basque country, but mainly they all shared some of the main struggles. Yes, thank you.
Thank you for the presentation. I have a question that is lying around the global competence standards that are proposed by WHO in the management of refugees and migrants. In as far as seeking care, when you look at what they recommend quite a number of standards. But of course, among them is what you presented as a very big problem in terms of communication and cultural differences, where we're looking at not just interpreters of the refugees and migrants, but what we call cultural mediators. And I think it is critical for you to appreciate those proposed standards by WHO to be able to address the different access challenges I'm seeing systematically. And as in your presentation, of course, we didn't learn about your healthcare system and how it is structured to be able to address these challenges systematically, and as opposed to how it is just spotted in a way of addressing these challenges. If you embrace refugees and migrants as a critical population for the country to offer services, medical services most especially. So I think it is very prudent that you probably throw light to us on how your healthcare system is structured, and then how you are looking or proposing, because you made proposals and recommendations on how to address, but they still didn't really didn't hinge itself on the systems. It hinged on a few spotted kind of efforts, not necessarily on a system kind of structure. So I think it's very important you throw light to us regarding that, so that we also have a leaf to borrow, if any. I thank you.
Thank you very much. Yes.
Start you.
Thank you very much. Pardon me?
Start you or answer you, or
you can go ahead. Yes.
Okay, so I'm totally agree with your question, because, for example, about the communication, all the doctors and the medical health cannot know all the languages that is speaking. They know a little English in some cases or French, but it's not enough. And there are some automatic translation services inside the Basque Country with mobile. There are online support translation services, but they are insufficient. We interview also, as I mentioned, 13 professionals of healthcare, doctors and nurses and so on. And sometimes the possibility to communicate with the patients are because the initiative of the doctors. They apply the mobiles and they communicate through the patients with their own mobile. So you cannot be attending in urgency or something like that with that mediums. They are asking for more and more automatic translation services. But also they put the emphasize that they need training. Because, for example, I mentioned very quickly about the skin problems, dermatologic problems. There are a lack of knowledge about here in Spain about the specific problems or with black skin, and they have to read books. And some patients, they say that they go with a book to the doctor, and the doctor and the patients are looking in the book to try to identify. So they cannot attend it like that. So they ask to the students of medicine or the students in the faculties in the university that we have to adapt it. It's necessary to training, and not only in diseases, also to training in knowledge about migration, because the mental health is very important to know which is the baggage of that people, how they came, how they live, how they have to hard work, and they have to know all the systems that difficulties in order to pay more attention when they are giving a treatment or something like that. So there is it's a challenge. It's a challenge because we have a lot of immigrations, and also you know that the healthcare in Spain is one of the most in the world, most open. So you can have, there is a lot of difficulties, as I mentioned, because to have all the things. But if you go to urgencies, in the first point, everybody is going to help you. So we need to training, and we need also to know more about automatic translation service, to know more about refugees and so on. I don't know if Andrea would like to add something.
No, I just wanted to thank you for your recommendation. Actually, it is true that WHO has standard on how to tackle these struggles to access services. We actually, with this study, we intend as well to advocate to public administrations and institutions to be able to raise awareness and raise visibility as well on these issues, so that they can also change the system. Unfortunately, I believe that these situations are more aware amongst the local organizations that work supporting these communities, migrant and refugee communities. And unfortunately, it has fallen upon them to work with the public administrations and create awareness about these specific problems. So currently, one of the activities and one of our strategies is to create awareness, but also to educate in informal and formal institutions, the future workers on health, so they can be aware of these situations and what the struggles of these communities are when coming from these backgrounds, specifically from context of conflict, because we know that there are specific needs that come from these communities, which are different to other migrants, for example. But yes, this is something that we are working together with the NGOs to be able to work with the local administrations. Thank you.
Thank you so much, Andrea and Nuria, for the wonderful presentation. We are so grateful to have you virtually here in Kampala. I think members, you could give them a round of applause for the wonderful presentation. Thank you so much. We will be transiting into a panel discussion where we'll be discussing frontline experiences in addressing gender-based violence. Before that, I would like to inform you that all these presentations that are being made, and perhaps those that you have seen, can be accessed in your just in free time. There is a QR code on that banner down there, the pull-up banner. You can just scan it and get the presentations that are being made. This session that is upcoming is standing between you and your lunch. And we are very careful about the time, but I am very confident in the person who is going to moderate this session. None other than Yakobo Kahesi. A gentleman who is coming before you is a medical officer and operations officer for AHA. He's going to lead us into the next session. Please, your seat as you clap for him, ladies and gentlemen. Thank you so much. We have Ms. Dalson Kusasira, who is a community services officer at the OPM. She sits in the refugees department. Kindly join Yakobo here on the panel. Thank you so much. Please give her a round of applause. I know you haven't had lunch, but these are powerful people coming through. We have our own Dr. Okware Michael. This is a health worker and in charge of Bujuwuli Health Center 4, and is also under medical teams. Thank you so much for gracing these occasions. Please, a round of applause for him. We have Anne Florence. I'm told this is a lawyer who works with AHA and based in Ichaka area. So please come forward. Thank you so much. Obugaro, those hands are, thank you so much. We have Lilian Ogusu. Anyone? Is she in? Thank you so much. She's a GBV survivor, but also an advocate. She will tell us more about some of those things. We have Pauline, Laquel. Anyone? Thank you. Please, some hand clap for her. These are powerful ladies that are gracing our occasion. And finally, we have an officer of the Uganda Police Force, Alice Malinga, who will be joining us to speak to us about issues around the police, but also the fact that she works within town at Old Kampala Police Station. You are most welcome. Like I said, Yakobo is standing between you and lunch. Depending on how he handles this session is how fast we are going for lunch. Thank you so much. And an administrative announcement, those of you who are still looking for lavatories or washrooms, we have one just here, walk here. And another one is at the space we had breakfast from, down. So feel free to use whichever one is convenient for you. Thank you. Over.
Thank you, Davidson. My name is Yakobo Kahesi, and I'm the Medical and Operations Manager of Africa Humanitarian Action. I'm not a medical officer, but I'm a medical laboratory scientific officer. I'm a medical public health officer as well. And like Dr. Justin was saying, inshallah, soon I'll also be a doctor of philosophy in global health. All right, so our session is simply about the experiences of the people who deal with GBV in the field. Our panel is made up of donors, monitors, doctors that are responding to lawyers that are doing the actual legal representation, SGBV officers, and we happen to have Lillian this time, so she has better experience than any one of us. And finally, our colleagues from police that are responding to these cases. So, to begin with, in only 1 minute, I'll give the opportunity to introduce yourselves once again and what your role is in the SGBV pathway.
Thank you very much. Good morning, everyone. I'm called Pauline Lake. I'm the Assistant GBV Officer with UNHCR. I'm in the country office here in Kampala and happy to participate in this. I work under the GBV unit. Thank you.
Good afternoon, ladies and gentlemen. My name is Ukusasira Dalson. I work with the Office of the Prime Minister, Department of Refugees, as a Community Services Officer. Thank you.
Yes, good morning, everyone. My name is Dr. Michael Okwera, the facility in charge, Bujubulia Center for, working with Medical Teams International, supporting case management. Thank you.
Good morning, everyone. My name is Anne Florence, and I'm a legal assistant. I work in Chakato Refugee Settlement.
Good afternoon, everyone. I want to thank everyone for being here. My name is Okuzo Lilian. It was earlier mentioned that I'm a survivor. I want to clarify that I'm a survivor advocate. I work with Alight. Alight is the lead implementing partner for protection within Chakato Refugee Settlement. More about Alight will be learned during my presentation. I serve at Alight as the protection manager, overseeing the entire programs. Thank you.
Good afternoon, everyone. I'm Alice Malenga. I'm a police officer. I'm attached to SGBV desk called Kampala, which hosts most of the refugees. I'm humbled to be here.
All right, Alice, stay with the microphone. So in a few minutes, maybe 2 minutes, tell us about your experiences as far as receiving survivors of SGBV at Old Kampala. What are the good things about your work? When the people come to see you, how do they get supported? And then just a simple hint on the challenges that you face as you do that work.
Thank you very much for giving me the platform. As I've already introduced myself, I'm a police officer, Alice Malenga, attached to Old Kampala, SGBV desk. We normally handle these refugees when they come. When a refugee comes before us, of course, the first thing we do is receive the report from the refugee. You have to make sure that you gain the rapport of the refugee so that you get information, the full information from the refugee, and don't be very inquisitive. Leave the refugee to tell you everything, what affected her, and don't play the blame game. If you play the blame game, the refugee will not tell you all the information, will begin fearing. So you have to sit in an isolated room. You create that rapport. You can even give her a cup of tea, a bottle of soda, or a bottle of water. So when you gain that confidence from her, she will reveal all what happened to her, and you will be noting out the points one by one. After her noting out those points, you will now record her statement. So that is the onset of forming up a police file. You register the case. You can identify defilement according to the story she gave you, or rape. Now, after you open up the file, you now identify, does this victim need safety, medical examination? If you have already opened the file, the next step is for you to tell the victim the right he has. How do you do that?
you have to tell her that when such cases happen, please come to police and report, don't fear. And then after you have registered this case, you have to cancel her on the police form, which we call police form 3. Because this case cannot stand without that case being filled. It's called police form 3A, where you write the details of the victim, the age, and the officer who is attending to the victim. Then it has to be stamped by OCCID. And this has to be done in presence of the guardian of the refugee. If the guardian is not there, an interpreter can be there. You can be having a refugee who doesn't have what? Who has a language barrier. So you get an interpreter who will be listening and guiding the refugee. Then you have to move for medical examination to our police facility in Zambia, where our director of medical services is. At our medical service, we have a counselor there who will first attend to the victim, counseling the victim, getting all the information. Then she will pass us over to the laboratory where the examination takes place. After the examination, we come back to the counselor who will usher us to the room of the police surgeon. The police surgeon will do the second counseling after the IO who is handling the file. After counseling the victim, we now go to the room where the examination has to take place. In that room, the police officer has to be there physically when the examination is taking place, and the guardian if he's there, so that you see what the doctor is doing, and so that that confidence you earlier on had with the refugee, she's very safe and it has confidence already in you, so she will not fear anything. So she will not fear anything. After the examination, the doctor will go back and fill the other form, what he had seen in the examination, whether defilement took place, whether rape took place, and if the defilement occurred within 72 hours, he has to introduce what we call PEP, and another pill which is called after emergency pill. They have to introduce it also. And if the victim is infected with HIV, he has to recommend for treatment immediately so that the victim begins taking medicine because she has already become infected. Now from there, you can come back to the station. And if the victim is pregnant, that is another thing altogether. That is now when we invite other stakeholders like these NGOs. We can even call lawyers from legal aid. They are very helpful to us because they give us facilitation. Sometimes we have clinics which partner with the police surgeon of Zambia. They are certified. So those police surgeons, you have to pay some little money. So when we call legal aid, they give us that facilitation. And even the facilitation of buying the PEP, they can facilitate and buy the PEP which the victim takes. Then they can also provide us with social psycho support. They can send social workers with counselors to come and be counseling the victim. And even they can talk to OCCID and the victim is taken to a safe place which is called a shelter. They can identify any shelter around. We normally work with other stakeholders also like Cornerstone, Wakisa Ministries. Then we have Talika. They are all helpful to police in facilitation and giving us shelters. So when this victim is taken to the shelter, we take her there with a reason to protect her from harm from the other perpetrators. The suspect can be arrested and is in cells, but his people will not be happy. So while this victim is taken, she has to be safe, and we don't have to reveal where we take her. The police officer has to be making after checkups. You have to make follow-ups to go and check on the victim, as well as the other psychosocial support will be continuing by the social workers who are assigned to her to do that work. Then on the side of the suspect, we have to examine the suspect on a police form we call police form 24A. This is a form which is used to examine suspects who commit serious crimes. In this form, the doctor will even put his age,
and his state of mind also. Now, after that, the suspect has to give police another statement called a charge and caution statement. It is a statement which is obtained from perpetrators who have committed serious offenses. After all that, the suspect is also examined by the police surgeon to confirm whether he committed the other act on the victim. So when all that is done, we can even get the blood swab of the suspect with the suspect. I mean the victim. The police surgeon will do all that. Then we shall fill a form called Police Form 17A, which is being submitted to GAL, Analytical Laboratories in Wandegea here. Then we wait for the results to be submitted. When all that is done, we submit the file to the resident senior state attorney. There now we can go and discuss with the senior state attorney, and we do what we call prosecution-led investigations for us to succeed. When the file is sanctioned, our perpetrator appears in court. When he appears in court and there are some other investigations the RSA deems that police should carry on, we'll send back the file, we complete those investigations, but the suspect will not be given bail in these lower courts because it will not be the jurisdiction. And when we are sending that file for the suspect to appear for plea, we send with a form we call a WT. That WT makes us inform our senior officers of what has happened in a particular police station. Now, when we are sending the file for the second time, we attach a form called Police Form 16 to inform our bosses of the progress of the case. Now, when RSA deems it fit for the case to be fixed for hearing, we'll now inform police. Then we shall attach another form we call Police Form 16A for the suspect to be committed to High Court. He has to be committed with that form which is when it is attached on that file. So our victim will still be safe in the what? In the shelter. When time for hearing reaches now, the date is fixed. It is the work of the probation officer or the social worker to escort this victim to court for her safety and for her to be having that confidence to testify in court. After testifying, still they have to escort that victim back to the shelter. So that is briefly what we do as police when we receive these reports. And maybe what I've forgotten is, of course, you don't submit this file to the resident state attorney without visiting the scene of crime. It is very important because we want to capture that evidence. When the victim was raped, did she forget anything there like a knicker? Or was she raped on a bed? Were bed sheets there? So we visit that scene with someone we call a scenes of crime officer. He's an expert in taking photographs where scenes of crime have occurred. So that knicker can be picked, or the bed sheets, maybe even the suspect also forgot there a cape, a shirt, or even a trouser. We pick it, then I put it in a khaki envelope. Don't put it in a cavera because you will lose the evidence. A cavera spoils the evidence. So you put it in a khaki envelope. Then you bring it to police. The scenes of crime officer will document all the scene. Then he brings all that evidence in police. We attach it in the file so that when the file goes, all that evidence will be attached. Thank you very much.
Thank you very much. It was not very brief, but I think what has been said, very many of you don't know. All right, so Lillian, as a survivor's advocate, just give us a brief about your experience with stigma as far as reporting of SGBV cases is concerned, as one of the barriers to reporting, and then the importance of safe spaces and community solidarity in SGBV management.
Thank you. I would expect the slides to be projected. I had earlier shared it up. As mentioned, my name is Okusu Lillian. Allow me to stand as I present. as the IT specialists are having that sorted, I want to extend greetings to everyone once again. And my name is Okuzu Lillian. I work with Alight, as earlier introduced. I want to give you a brief. Someone guide me on how to use this. I like being open. If I don't know something, I have to be guided before I make mistakes. Well, thank you for taking me through that. Learning takes place every day of our lives. There's nothing much under slide 1 to talk about. I would want to proceed. In the overview of my presentation, I would want us to look at the refugees and asylum seekers in Uganda, the overview of possibly displaced and stateless persons, which is the current terminology we use to describe who a refugee is for dignity purposes. Then I will have a look at the Allied geographical scope, overview of Allied interventions, some key statistics. Now we'll dive into understanding stigma, barriers to reporting, safe spaces, community solidarity, and should there be any questions, we'll venture in them. I'm going to be a bit fast in an event that a given presentation doesn't need a lot of time. We sit and respond to refugee situations in Uganda. By the time of making the presentation, I was referencing to the statistics as of 30th September 2025, and the overall population size of refugees and asylum seekers in Uganda was standing at 1,955,370. This is with reference to the OPM database. The other breakdowns are all there seen. Those who amount into refugees, asylum seekers, and you can note with me, the greatest percentage is for women and children. There are settlement-specific populations which contribute to the overall 1 million and something that I earlier mentioned. Since you can easily have access to this presentation, I would want to proceed. Context specific of that, what speaks of Chaka 2? Chaka 2, by that said, a timeline of 30th September, on the dashboard, we had a population of 136,915, and the other breakdowns are also there as seen. And the countries where these possibly displaced and stateless persons are coming from, the highly recognized are those from Democratic Republic of Congo, followed by Rwanda, Burundi, and South Sudan, which is the smallest population. Other under operational setups, Chaka sits within 9 zones, and in those 9 zones we have 26 villages. We have 56 organizations, including international government organizations, national and also refugee-led, and of these 56, 19 are directly responding to GBV needs. We have existing community structures. I've only picked those which are applicable to protection, and I've left out the elements of structures that work closely under health, who are the VHTs, education, and the like, so you'll excuse me, but if you need more data, we'll be able to share. So we have functional coordination platforms, which have the sector working groups, the settlement coordination. It helps us to put our in-house in shape. About Allight, formerly Allight was known as American Refugee Committee, and we are long-standing in operation as far as Uganda is concerned since 1994. We are the lead implementing partner for UNHCR under protection. We also manage transit centers and reception centers, and our operational settlements are those listed in Nakivale or Ruchinga, which is within Singiro District, Chaka 2, located in Chegegwa, Rwamwanja, which is located in Kamwenge District, Changwali in Kikube District, Bidibidi, Yumbe District, Rhino Camp, Mariokolo District, Pakere in Ajumani District, and also the said transit centers, which are being mentioned, the Nyakabande, Matanda, Bubukwanga, plus others. I think in the projection you can read others. Allow me proceed. Under our protection, Allied strengthens the protection of protection environment and improves inclusive protection services, emergency response. We also improve access to emergency supplies and protection support services for new arrivals. The livelihood component, more is being highlighted there. I wouldn't want to spend much time since we are standing between you and lunch. I want to be sure that I've not, okay. About the gender-based violence services that we render, we have case management, psychosocial support, linkages with legal, health services. We also venture in one-stop center operation jointly with the medical teams within the health facilities. We have protection house management, safe spaces for women and girls, which are currently being managed by the community due to the fund cuts. Then we are having system strengthening. We have worked in coordination and collaboration with AHA and the MESCO, and this has helped us to achieve these that I have listed up there, the referrals of identified GBV and legal services, then joint community awarenesses on GBV prevention and legal-related matters, the mental health psychosocial support services that AHA also supports us to render to the community. AHA also helps us to do court follow-ups and for GBV survivors, the capacity buildings for community structures and stakeholders, safety audit assessments, material assistance in the case management processes, and supplementary medicines for GBV response. As far as the PEP and emergency bills are concerned, by end of September, our GBV incidences that we had recorded were 247, directed by Allied, because Allied is the case management partner. 100% of these were female, comprising of refugees, asylum seekers, and the barriers like stigma, gender norms, and also some men feeling that services for them are not accessible hinders them from reporting. But time and again, we are working to eliminate this and also put them on the same space so that they can feel heard. Please note that these figures are not indicative of the prevalence of GBV in Uganda, but it indicates data added by specific GBV response partners using the GBV IMS under the Uganda GBV response plan. Much of this is what we capture in the GBV IMS using the incident report tool. Should there be need, you can get the slides and understand them so much detailed, unless if someone feels that I need to take through, I feel it might take us more time. But in summary, the first area that talks about the incident per GBV types, those are the types of GBV or the forms that we pay attention to, including the denial of resources, which has been the greatest, the psychological, emotional abuse, rape, physical assault, sexual assault, forced or early marriages. Those are practices now. So the incident times, as per that, we know majority of the cases occur at night, as per those that have been reported, afternoon and morning, as rated by percentage, and the gender breakdown, the female and male, is what is seen right up there. Primary perpetrators estimated age group, majority of them fall between the ages of 26 to 40. Then it takes us to 41 to 60 to being the second. we go to 18 to 25, then the 60 plus who are older, and also the unknown, because there are some survivors who may not have clear data to give us, and we take note of that. I would want to proceed. Pardon? Okay. Proceed in taking us through the critical areas of understanding the impact of stigma on survivors. First of all, what is stigma? Stigma refers to the social disapproval, shame, and silence surrounding survivors of abuse or trauma. It is best felt in a person. Going ahead, we have anonymous survivor testimonies to give, which can help us to align the definition of stigma. We're having a young woman in a rural community who was ostracized after reporting sexual violence. Her story was dismissed and she was labeled dishonorable. Another anonymous testimony, I stayed silent for years, not because I didn't want to speak, but because I didn't think anyone would listen. So the forms of stigma, here we are looking at the social victim blaming. We all know in our social circles what we are capable of doing. Sometimes we are the reasons. I'm using we because we are here for the training, but it goes beyond us. So sometimes we blame people and make them to feel silent, to feel underprivileged, to be heard, and also to access resources. The cultural taboos and norms, how does it manifest? We all come from cultures that has abiding, I would say, many observed bylaws to some extent. It may not be the right word to use. I want to give an example of issues surrounding our marriages. However much marriage has unique considerations that we pay attention to, there are very many people out there who are cohabiting. But at the end of the day, do they have access to resources? So this marriage break. Lately, there are policies that are being under review to see that such critical areas are being taken into consideration, but they're not yet fully in action. The issues of GBV being looked at as a domestic issue and not worth to be shared out are some of the manifestations in those cultural norms taboos. The gender-based discriminations, we all can define gender, and when the discrimination is based on gender, we all know how socially we align beliefs, responsibilities, roles to being a woman, man, girl, and boy, and it's one of the forms of stigma should you be attached to one and negatively. The institutional disbeliefs, victim blaming in systems. I'm sorry to use an example of police, but usually these blamings and unprofessional conducts are mostly done by unprofessional people also. Have I ever had experience in the GBV response where when we are responding to a reported defilement case, the police officer in question, I wouldn't want to mention even the station where they're coming from, say, these young girls, this is what they're looking for. Why should you move alone? Why should you dress poorly? Why should you do, in the presence of a survivor? And you're trying to make this person feel that they are a cause of what they have gone through. If it was you or me, how would you feel? Instead of responding professionally. Some of those are just examples that I can give, but we're not going to limit it only to that. So the impact of stigma, we look at the survivor's mental health and wellness. Earlier, students of research were telling us those traumatic experiences that you're trying to clarify to us here is the PTSD, that one now. Yeah, so trauma is something that you can live with should you have an experience to testify. So it's one of the mental wellness that we are looking at. The retarded physical well-being. If an expert walked in this room, by sample of people would easily tell who is going through something. I wouldn't want to touch much because we are here to set our brains in the room and learn, but we can learn through experience. Self-worthlessness is that feeling of, I don't fit to be alive. Why is all this happening to me? Why all this? By the time you reach that extreme, just know it's getting too much. The withdrawal to access support. Once you're blamed, once you're not given a listening ear, once you're not welcomed, you'll obviously lose the morale to access services. Even if it hits you like how, you will lose that. The impact of stigma, already the manifestation in the community norms and all that is what I already explained. For us to challenge stigma, we can venture into awareness campaigns, exercising empathy and understanding, having that welcoming art, listening to someone, understanding, and offering support, not just by judging, but by linkages. Can venture into education. I've just listed them since they're simpler to understand, but should there be need, you'll get back and I'll take you through. The barriers to reporting. Why survivors often remain silent? We have both internal and external contributing factors. One of it I want to look at from the internal or personal barrier is the fear of not being believed, fear of retaliation. However much you may say, there's that fear that they will not believe me. They will feel I am not giving the right information, or I am attaching more attention to what doesn't exist. The fear of retaliation, what will come after? Won't this person do worse than they have done? Won't they plan and do something extreme? The lack of trust in institutions or authorities. I earlier shared my experience, and it goes beyond only police. We call ourselves as service providers or responders, but how do we frustrate the response processes? What attitude do we have when we are responding to the needs of the survivors? Are you being a professional, or you're bringing your personal understandings to frustrate someone? Shame and guilt. Instances where somebody will feel ashamed and guilty for the consequences of reporting. Trauma response, the other time, and until now we are still managing the impact of the funding freeze from the US government. And we all know, those of us who operate in the settlement, how the funding situation has become most wanting. You no longer have reliable services from partners like it used to be, because people are scaling down, and there's no operation you can do without resources. Everything always has the resource aspect attached. The external barriers, cultural or society norms that silence survivors, the threats from perpetrators, social and economic dependence, pressure to stay silent, fear of community, family backlash, re-traumatization during reporting process by unprofessionalism, community fraud. There are instances when the community structures we have look at the art of being a survivor, being a business opportunity. We have had testimonies from survivors that should you be in need of a community structure to link you or to forward you somewhere, first of all, sometimes the community structures make it be believed that it is through them that the survivors can access other services. So when that mindset is put in the community, people will always first look at this leader as a bridge. And should they reach and he charges money, you don't have the resource. Someone earlier talked about categorization. Category 1, 2, 3. When you're in category 3 under the World Food Program assistance, you will not get anything in terms of the monthly cash for food. You're rendered capable to provide, but are you capable? Amidst the challenging situations to provide for yourself and your family, you may not have the resources to give whoever is asking you money. An anonymous example, a male survivor feared ridicule and loss of masculinity if he spoke out. He kept silent for over a decade. It's important to note that when we address these barriers, we will create a more supportive environment for survivors. Some of the reporting mechanisms, this is Chaka context specific. We have the protection desks, which exist at the zonal levels. We have the community structures. I earlier gave an example of who those community structures are. We have feedback, reporting and referral mechanism, the FRM, which is centrally managed by UNHCR. And should there be a call to that effect, it is channeled to partners to respond. We have the suggestion boxes, women and girls safe spaces, the peer support groups, the one-stop center. The importance of safe space. We need to know what a safe space is. This is a judgment-free, supportive environment where survivors are lived and supported. Yes, I'm finishing. This is actually the second last slide. It can be physical, emotional, as best outlined there. The critical components of it, the confidentiality and trust aspect, the empathy and understanding, the accessibility regardless of socioeconomic status, the survivor-centric or centered approach, where interventions have to be designed and run by all with input from survivors. And those are the benefits of a safe space, which encourages disclosure through experience sharing, promotes healing and empowerment. The trauma processing aspects are being looked in, builds trust and community. In an anonymous example, is a survivor found healing through a community art therapy group where she could express her pain without words. More of those anonymous are in the safe spaces where one mentioned at some point, this space healed me, now I help others find their strength. Before we suffered in silence because we didn't know where to go. Now I have a phone number saved and I know the path to the support center. The last slide being the community solidarity. Community solidarity looks at listening without judgment, advocacy and allyship, policy change and education. Example is all there. And the call to action is the individuals educate themselves, support services, challenge stigma, communities build safe, inclusive environment, institutions implement trauma-informed policies and survivor-centered practices. And I would want to conclude by saying that if there was time, we would all have an opportunity to write one way that we think we can support a survivor from what I have taken us through. And in my final message, I wish to say that when survivors speak, the world must listen, not with pity, but with purpose. I want to take this opportunity to appreciate the government of Uganda, UNHCR, all presented here, the management of Makerere University, the research students, as the frontliners who are in the field, and in a special way, I also want to recognize the funders who have enabled this exercise to take place, SGBV in particular, as well Farmamundi. We have been mentioning more of Farmamundi, leaving out SGBV, but I want to recognize their support as well. And I believe by having such interventions, we will create change, not only to identify problems, but also work on solutions and respond. Thank you so much. For anything I've left out, you can guide or ask for more guidance.
Thank you, Lillian. I think that was comprehensive enough. I highly doubt if there'll be a question on that front. Ana Flores, from your side, a few barriers to justice for survivors, the importance of the courts, that includes the mobile courts as well, some legal clinics, and then the need for survivor-sensitive legal processes.
All right, thank you. Once again, my name is Anne Florence, and I'm a legal aid provider. As earlier mentioned by my colleagues, Uganda hosts a big number of refugees. But from these very many refugees that are in the country, we still have a very big number that are not familiar with the justice system. You find out that, of course, they are from different countries. The laws from those countries are not the same as the ones in Uganda. So when they reach Uganda and they are faced with a legal challenge, of course, navigating the justice system becomes very difficult to them. So I'll begin by mentioning some of the barriers that they face when trying to access the justice system. One of the major barriers that the survivor faces is late reporting. You realize most of our survivors, especially the ones for sexual violence, like rape, defilement, some of them come late, a week later, 2 weeks later, and report that they have been raped. Of course, for the justice system, they work based on evidence. A survivor will have to pass through the police. The police will conduct its investigations, try to visit the scene of crime, trying to get some evidence, and yet a survivor has reported maybe a week later or 2 weeks later, and the evidence may have been washed away, maybe the survivor's state of clothes, even the medical form from the hospital, the police form that the police gives when you're going for medical examination. Definitely, if a survivor reports late, the medical practitioners may not be able to get any evidence there. So when a survivor reports late, it affects a survivor in terms of seeking justice. The case will be moved to court. And of course, at court, the magistrate or the judge there will look at the evidence presented before him. If a medical report says, I do not see anything, the hymen, there are no bruises, maybe the survivor already healed at the time when the survivor was going for the medical examination. The police report, of course, there was no evidence got at the time of the investigations. In most cases, the case may be thrown out. The survivor's case may be dismissed and the perpetrator will be left to move freely. He'll be back to the community. And of course, at that point, a survivor will feel like I have not been supported. The justice system has failed me. Yet it is the fault of the survivor, maybe because of the knowledge gap, and the survivor is not aware that, oh, there is a 72 hours time for reporting, and the survivor came later than this time, and there was no evidence. And also, when a case moves to court, I'll use the context of Chaka 2. Chaka 2, of course, we have refugees from Congo, we have refugees from Rwanda, Burundi, and other minorities. But when you look at the language of the court, of course, is English. And for a court session to be considered fair, of course, both the parties, we have the survivor and the perpetrator, they must all be able to follow and fully understand the proceedings of the court. So if the magistrate there is speaking English and the survivor speaks Swahili, the perpetrator is speaking Kinyarwanda, of course, the court will not be able to proceed without an interpreter. So if there is no interpreter for these court sessions, the cases get adjourned, and the survivor comes to appear in court another time and another time, and the cases get adjourned. So basically, I'll still use Chaka. In Chaka, we only have one court-trained interpreter. Of course, he only appears in court if he is facilitated because he's not under the judiciary. So every time cases are coming up for hearing, the interpreter has to be availed to the court. And where he is not available, of course, the case is adjourned. A survivor can come to court this month and they tell you, maybe return next month. The case has been adjourned to maybe December, and the survivor returns again December, and they tell you January, because court cannot proceed when the survivor does not understand the language of the court. And of course, when a case is adjourned several times, a survivor gives up. They lose interest in the case and feel like maybe there is no justice. So they abandon their cases in court because of those small challenges. And also, when you look at still Chaka 2, our court is a bit far from the settlement. It's about 20 kilometers from the settlement. And yet all cases from Chaka 2 have to pass through that court. And then you look at our survivors, many of whom have been removed of the monthly cash ratio. Someone can barely afford food, and you are telling a survivor to move a distance of about 20 kilometers. That is about also roughly 20,000 shillings. And the survivor is getting 10,000 per head as monthly cash ratio. This is really expensive for them. So when a survivor goes to court the first time and the case is adjourned for further hearing, goes to court the second time, again it is adjourned. This is money from a survivor's pocket, someone who can barely afford food. So it becomes very expensive, and of course, many give up along the way if not supported. So those are some of the major challenges that survivors face when trying to access justice. I'll go to the importance of mobile courts. Majorly, a mobile court means shifting the court from its traditional sitting place. I'll still use Chegegwa. You move the court from Chegegwa, where it is seated, where it is situated, and take it to a place closer to the community. Like in Chaka, of course, we move it to the settlement. We look for a secure place in the settlement. Like usually when selecting this place, you look for a place that the majority of the perpetrators come from. You look through the cause list, and maybe if they are coming from Bukere, you will situate the court for the hearing in Bukere. And then, of course, you work with the judicial officers to make sure they are present for the hearing. You work with the prisons to bring the prisoners. And if there are other perpetrators who are out there, maybe on bail, they're also brought in to court on that day. And then, of course, the witnesses and the survivors are all informed that there is court in the settlement. The community is informed, so the court is within the community, and other community members, even those that do not have cases at court, are able to participate and fully follow the proceedings and know the outcomes of the court proceedings. So its importance is that, one, when you bring the court closer to the people, of course, services are brought closer. That issue to do with transport, you've provided interpreters. Of course, during these mobile courts, you provide at least 2 interpreters, Kiswahili, Kinyarwanda, so that there is no issue with maybe interpretation and language and judgment. So the court is closer to the people. They are able to move to the court because it is in their community. Cases will not get adjourned. And then also interpreters are there in court. They are interpreting for them in the languages that they understand so that the hearings are fair and impartial. And then it also creates awareness. Yes, because the community participates, even those that do not have cases at court, because it is in their community. In a secure place, there is security, police has been provided, the prisons officers are there, so the community participates. They are able to see that indeed when you commit a crime, of course justice can be served. The perpetrator can still be convicted. And then I'll refer to my notes a bit since we are not projecting. You see, when the court is in the community, of course, for people out there who are also attending, the members of the community, the leaders, it sends out a message to the rest out there that, of course, when you commit a crime, you can still be convicted. So those who may be out there and also intending to commit crimes, it may deter them from committing further crimes. They know I'll be convicted and I'll be sent to prison. I'll move to the need for survivor-sensitive legal processes. Basically, a survivor-sensitive legal process, when you're observing this survivor-sensitive legal process, of course, you put the survivor's dignity, the survivor's safety, and the survivor's well-being at the center of the justice system. In short, you make sure a survivor feels heard, a survivor feels supported, and a survivor should feel respected throughout the legal process. So one thing we all acknowledge is that a survivor vulnerable. Of course, they are vulnerable. They are traumatized. So when you put the survivor-sensitive legal process into effect, you make sure cases do not get adjourned for a long time. A survivor should not feel frustrated moving to court every now and then and the case is adjourned. Like when you mobilize a mobile court, of course, mobile courts are made to ensure that justice is delivered in a fast and efficient way. So when the court is in the settlement, they will have no reason to adjourn. The cases will be heard and resolved very fast. So we also look at our police because this is where the survivors, in most cases, reach first. So if the police is trained to deal with survivors, when handling survivors, they should deal with survivors with some empathy. They should not use words that re-traumatize us. And also the procedures at the police should not re-traumatize a survivor. They should be trained on how to handle a survivor. So, of course, when we organize mobile courts, we usually provide interpreters. So when a survivor is able to follow the proceedings are, of course, in their languages, they are able to understand fully and follow in such a way the survivor feels safe. And, of course, participate fully throughout the process rather than leaving a survivor to struggle with English, and this is a language that is not in their country of origin. And finally, of course, justice should not depend on a survivor's ability to pay. When you look at the distance to Chegegwa, that is very far for a survivor. For a survivor earning 10,000 as a monthly cash ratio and has to travel 20 kilometers to Chegegwa, that is too costly for them. If the court and justice is very accessible for them, this will make the process very efficient and fast, and the survivor will not be re-traumatized or re-victimized. Thank you all for listening.
Thank you very much, Anne Flores. I'll now move on to Dr. Okware. Dr. Okware, you're working in the health facility. So just a bit about the realities in the health facility, the resources, how are you handling, and maybe some challenges in the psychosocial section, SGBV.
Yes, thank you. Yeah, maybe with the project, I think I shared. Yeah, maybe as they're preparing to project, I'm Dr. Michael Okwera from Bujubulia Center 4, which is located in Chakatu Refugee Settlement. It is one of the referral sites where we receive quite a big number from outside the settlement, mainly the national community. So the facility is a high volume. The lead health partner there is Medical Teams International, supporting refugees and the host communities. Medical Teams serves Midwest and also in some part of West Nile, that is Adjumani and Moyo, providing health to refugees and the host communities. I'll be talking mainly on the part of clinical management of REP. I don't know whether the presentation is coming or... Yes? You have the presentation to be projected? I had shared. Anyway, thank you. I think I'll just try to highlight some of the areas. In Bujubulia Center 4, we serve about 82,000 population. That is for the catchment population for the facility. But as per the settlement is what has been already communicated, is around 136,000. And we have 3 health facilities right now, and then 2 health outposts from a total of 9. Because of the budget issues and the fundings, they have reduced the number of health facilities because all the 9 zones are used to have at least a facility to support patients. But right now, as we talk, from 9, we have dropped to 4. Yeah? That is what we are surviving on right now. And we receive about, when I look at the data which we collected from January to September, we served about 400 individuals. That is both the physical and sexual violent cases. But when we look at sexual violent, we served about 127,000, in which 99 are refugees, and then the remaining balance, 28, is nationals. So these cases are received, mainly can be through OPD, and then also we have a one-stop center where the lead partner for protection, that is Allied, sits, and sometimes some cases go straight there and identified from there and referred to a clinician to examine. So what we do, we provide these services, mainly starting with the clinical. We take the history of these patients, we examine them, we provide the care, emergency care, especially for those ones with the trauma. If someone is bleeding, we make sure that we arrest the bleeding. If someone had fractures, it is immobilized, a painkiller is provided before any medical legal documents is completed or filled. Yeah, so or even before the forensic sample has been taken. So that is part of the care that we give immediately when the survivors reach the facility. And then also after that, we have to at least do more investigations. We investigate these clients, mainly for HIV. If they are negative, we provide them with PEP to start immediately. And then those ones who are positive, we send them to the art clinic to be initiated, as the current policy is test and treat. That is what we are implementing. So every patient, a client who tests positive has to be initiated on ARVs immediately or within the first 7 days. So from there, we also screen them for pregnancy. If we are to look at the data that we had that are generated, you'll realize that majority of these patients come very late, more than 120 hours. Yes, and that is our limit to provide emergency contraceptive pills. For 72 hours, we give oral contraceptives, and then for the other remaining hours, to make 120 hours, we always provide IUD, yeah, to prevent pregnancy. But you realize that most of our clients reach facility almost advanced in their pregnancy, and most of the time you have nothing much to do but to continue. They also refer them to antenatal to continue with the antenatal care. Of course, most of them are already even has been already enrolled into antenatal, and you just continue. Most of the time, you have nothing much to do at that point. And then the other thing is some of them are also identified during labor. Yeah, especially for the young girls. Of course, someone will be prompted to ask some few questions, administer the checklist, and then you realize that this client was an SGBV case which was not identified or which was not reported. So some of them, we capture them during labor, and we provide them the services, we deliver, and then, that is how we sometimes identify some of them. And then also after the investigations, we are required to fill the medical form 3, which is from the police. And this is part of our referrals because after providing all the clinical care, you're supposed to refer. And before I forget also, we also provide prevention and treatment of STIs, yeah, before any referral to the protection team. So that is the steps that we do. And as per the numbers, as we have already said, we try to differentiate, also categorize. We add the defilement numbers, and then also the cases of, out of the 127, also the cases of rape. Yeah, we realize that the clients below 10 years are very many also. So, and these are the cases of defilement that we always have within the community, 15 and below. And then the dominant cases of sexual violence is from 15 to 25. They dominate, and then above, there are not so many. Yes, so briefly, that is the background that I wanted. And then the challenges. Some of them I've already said. Late reporting is one of the biggest challenges. At that point, as she has already said, you have nothing to do. Even the legal teams might not do much. Yeah, because at that point, we can't get any forensic samples. We can't do anything. So if a client is already pregnant and has come maybe at 8 months, the only thing is to continue with the care and provide the necessary support that is needed during that period. And we also have the issues of critical staffs. When it comes to We have seen the reduction in fundings, which has affected facilities. All these facilities had health workers, but all of them have gone home. So some of them have been trained, some of them we have been supporting providing these services in these facilities. But now when they send them home, of course it creates again another gap, which is the distance from the main facility, which is Bujubuli and then the other two health facilities. Yeah, and then the two outposts that we are supporting. So that is distance from the health facilities is affecting very many to report and to get the care that they need immediately. They have been raped or they have been assaulted sexually. We also have issues of supplies, out of stock of essential supplies. If we had also looked through into our data, we realized that there are periods where even testing kits were out of stock. Even the contraceptive pills, the one which is supposed to be available almost 24/7, it will also be out of stock. And at that point, even if you screen a client and is not yet pregnant, sometimes it becomes hard for you to do something to prevent the pregnancy or the HIV, which is a deadly disease at that point. So those are the things that we always go through. And then also follow-up has also been a challenge because of the issues of funding. Sometimes these patients come from very far and you have to go. A health worker is supposed to visit these people or call them to come to the health facility to do follow-up, because when you give PEP, at least within 1 month, someone is supposed to come back. You repeat the test if someone has seroconverted or not. Yeah, so, and even still pregnancy, they're supposed to come back for routine monitoring. Yeah. And then we also have issues of the mobile population. This population is on and off. You realize that that population that we have shared, in the next few weeks, you find that it has changed. Yeah, because people move. It's a very mobile population. So it also affects us. When you have identified maybe the survivor, you're supposed to follow up. And when you reach there, realize that maybe they have migrated, either moved to another settlement or moved to Kampala, something like that, or they have moved back to Congo. Yeah. And then on the challenges of psychosocial support, as medical teams, we don't do much in psychosocial support, but of course, as a health worker, we're supposed to provide these services. But the lead partner, we are working in coordination with the lead partner, which is TPO, which provides, they have psychologists and they support these clients. Always when we receive these clients, we refer these clients to the lead partner for psychosocial support. Yeah. So the biggest challenge is now the critical staffs. Like the whole settlement, we have one psychologist which is supporting that, and it is affecting the service which is supposed to be offered. Yes, and then also still on the issues of distance, some of the clients do not follow the dates, the revisit dates which has been provided, so they will not come back or they will not adhere to the services that you provided for them to follow. Yeah, so you might not be able to assess your client whether he's coping up or not. So that is mainly the biggest challenge with psychosocial support. The good thing, we have a one-stop center where all the three team, that is the clinical case managers, we have the protection, we have the mental health and psychosocial support team. They are supposed to sit in one service point. That is a plus for us. They are also, because we receive some small fundings, they are expanding it. So we hope that it will improve some of these gaps that we have explained. And then also we are going to do more of a talking compound where someone who needs the service doesn't need to go to someone to ask, just look at the things, the directions which are within the facility. So I think that is the upcoming thing that we're going to work on. Thank you so much.
Thank you very much, Doctor. Before I call the big people, I want us to wake up a little bit. Moses.
Okay, let's just stand up a little bit, stretch, and then we wind up with this session. It's very good for your health. Whenever we have such kind of presentations, we tend to use a lot of the brain. Now we need the whole body to do. So I am more in bones. Now I'm going to teach you a little bit of bones. But for us in bones, we number bones. Yes. So the first bones, these are the first bones. Always like number 1, number 2, number 3. Okay. So now we are going to do bones. Okay, let's go. Number 1, number 2, number 3, number 5. A bit faster. A bit faster now. Okay, 1, 2, 3. Let's go. 1, 2, 3, 4, 5. Now I'm coming with a different order. Yes. 1, 2, 3. Let's go. 5, 3, 2, 4. Thank you very much.
All right, thank you, Moses. Dalson. OPM as the leader of the refugee response in Uganda. Give us a little bit about the coordination role that OPM plays, the challenges in settlement level protection, and the government's effort to strengthen these pathways for GBV.
Thank you. Good afternoon. The government, through the Office of the Prime Minister, Department of Refugees, plays a coordination role and brings together all the partners implementing in the refugee response, both international, UN agencies, and community-based. So it brings them together to understand how they are doing the implementation. And these partners must apply through the Uganda Refugee Monitoring System, URRMS, where they acquire MOUs so that they are able to implement in the response. So we do coordination with them and also coordinate with line ministries, departments and agencies, and partners like AHA, partners like AWARD that implement GBV specific, but even those that implement other interventions, we partner with them since we do the coordination at OPM. We ensure that OPM coordinates these partners and links them to other ministries and agencies. For example, work with the Ministry of Health to ensure GBV survivors access health. We work with police so that perpetrators are apprehended and survivors get justice. We work with the Ministry of Justice and Constitutional Affairs so that perpetrators are able to have justice and perpetrators are apprehended. So that is what basically we do with coordination. And as government, we work with partners and ensuring that we do referral pathways, which is, now we are working with communities. We are doing integration of services with government institutions. Initially it was humanitarian, but now it is humanitarian development, and the resources have gone down. So we are ensuring that we integrate these services within the government institutions so that we are able to access services. However, we are seeing that even from the doctor's presentation, the government also doesn't have resources. And we are finding that some cases are lost because we don't have these resources. So what we are doing as a government is we need to map out services so that we know that we have a number of services that are mapped out for GBV. We know that health, health justice are mapped out so that we are able to refer our survivors for appropriate services. Then we also need to establish a referral protocol so that we are able to establish these protocols and partners go to these, the survivors can go to the established safe spaces where they can access services. Then as government, we also need to promote interagency coordination so that we can foster collaboration between government, bodies, and civil society so that we get we have a multi-sector approach towards GBV. Then also have to incorporate community feedback so that since this is survivor-based and we get feedback from the community so that we work on the feedback that is got from the communities and we're able to have an approach that is survivor-based. Then as government, the challenges that we face, we don't have the reduced resources vis-a-vis the big numbers of refugees. Everyday refugees come in, yet the resources keep reducing every day. So we request for more resources and we are working. That's why we're also doing integration, that if the partners are not bringing or the donors are not bringing the resources, then the refugees can access the services that are already established in the government systems or government institutions. Then we also have challenges of the communities where these refugees live. There is no confidentiality because the refugees, especially in the urban, live in densely populated areas and the low-income areas where there is no confidentiality. If an incident happens, everyone in the community will get to know, and this one causes for stigma. So we need to also see how to work with government to ensure that these refugees can stay in some places that a little have that have some confidentiality and privacy. Yes, as government, we call upon the partners to have integrated services so that GBV is integrated in the mainstream together with sexual and reproductive health so that these services can be accessed in a one-stop center. Like the doctor has said, if this one-stop center are everywhere from Chaka to Rwamwanja to Adjumani and even in Kampala, it will be easy for the refugees to access. And then also to have, together with mental health, because if you look at what we are doing, mental health is one of the components that has not been given attention. Yet GBV affects refugees differently, and the host community, the vulnerable host communities, it affects their mental health, it affects their physical well-being. So we need to also integrate mental health, GBV, and sexual reproductive health in the mainstream government system so that refugees and the most vulnerable host communities can access these services. We also need to call upon donors to support, in case there is more funding, to come and support the operation since the resources have really gone down and more survivors are coming. Justice is delayed, like we have heard from the previous speakers, so that we are able to give justice to the survivors and also to do preventive measures. Thank you.
Thank you very much, Dalson. And finally, Pauline. As UNHCR has the international mandate over the care for refugees, what are the protection priorities as far as SGBV is concerned, and what role is UNHCR playing in strengthening case management?
Thank you very much, and good afternoon. We have, and from the previous presentations, we have a growing refugee population and reduced funding, and that calls for reprioritization of our GBV efforts. Now, UNHCR, by our mandate, it's protection of refugees. And UNHCR does not work standalone, but supports the government to implement all the different activities. And what has been the priorities right from the onset? UNHCR supports and ensures that GBV is prevented right from the onset of emergency. In our work, we do assume that even if gender-based violence is not reported, it's actually happening. And that's why right from the onset of the emergencies, all the frontliners, there is a protection desk that is established to see that people are informed about the services and survivors can quietly go and seek a service from a protection staff. And then there is also a lot of work being done on gender-based, on GBV prevention, which is critical. I did hear the presentations from the students and from the partners. The root causes of GBV are linked to issues of harmful traditional practices. And these harmful traditional practices, issues to do with the power imbalances, can be addressed through the community-based approaches. The students did talk in their recommendations that need to work with the religious leaders, the academia. You need to work with the community-based leaders. You need to work, and it's part of our priorities in line with government that all stakeholders need to enhance community engagement on GBV prevention, empower the communities to take lead on talking about issues of gender-based violence, in creating the awareness, in doing the day-to-day support. And that means that the priority is shifting from agency-led GBV prevention activities to community-based led activities. For communities to take lead in the campaigns, communities to have interactive conversations about gender-based violence in their families, in their communities, and be the supportive hand to be able to speak about it and prevent. And that is a critical priority in this environment that funding has dwindled down. We continue to see funding dropping, especially this year. We have a shortfall on staffing, with caseworkers handling the caseworker ratio is 1:88, as opposed to the standard of 1:20 at a time. So with all this reduction of staffing, and heavily this year, it calls for a reprioritization of our work. The need for us to do more with less funding, the need for us to work differently as opposed to the old way that we have been working. When I hear the recommendations of do this, do that, do this, at the back of our mind, we should be thinking, with no funding or with less funding, what can we do? And that's the conversation, that is the reflection that we continue to have in liaison with the different governments and the different UN and stakeholders while guiding interventions moving forward. What is another priority that we do look at? We do recognize that refugees have local expertise. We have community-based organizations that are already playing a critical role in addressing issues of gender-based violence even in the humanitarian districts and the non-refugee humanitarian districts. And what does it call for? Empowering these community-based organizations, some of them are refugee-led, to be able to conduct the day-to-day work that we are doing. Why? Because the challenges that you talked about, language barrier, reaching out to the deeper corners to identify survivors, it's much easier where we already have established community-based organizations within the communities. They can be the first responders and frontliners. And this does not mean that we are putting away the international organizations, but they will be complementing the ongoing activities by the different stakeholders in addressing issues of gender-based violence or prioritizing GBV prevention, response, and risk mitigation. Thirdly, another critical priority is integration of services. My colleague from OPM already talked about it. And from your different presentations, we do hear that we are seeing mental health a big burden, a big issue among caretakers. Persons with disability are left out. Refugees are left out. All different groups are left out. And part of our efforts in Liaison with the different stakeholders is to see that services are integrated. For GBV particularly, we need to focus more on comprehensive service provision as opposed to psychosocial health, etc., and strengthen comprehensive service provision of GBV, ensure that issues of mental health are integrated into our GBV response, because this one mainly focuses on basic counseling to survivors, but also integrating the other key components through the one-stop centers and see that the services, one is able to get comprehensive services to their needs. And this is also a call, what's the call to add? And this is also a call to action as we think of our activities moving forward or our strategies that we are carrying on. For all these that we are doing, what are we able to do with less funding? And how can we think of more sustainable activities and work more with the communities to be able to address issues of GBV and also mitigate the vulnerabilities or risks of GBV happening? One critical thing that we see in our experience with working with the frontliners is that with the reduction of food aid, with the reduction of funding, we are seeing an increased risk of GBV and issues of sexual exploitation, and then increase on negative coping mechanisms. And therefore, this requires a deeper look at the concerns and work along with the different actors to be able to address some of these emerging risks that are coming out of the reductions of funding. So thank you very much, and those are some of the key priorities that we are looking at.
All right, thank you very much, Pauline. In the interest of time, I'll only allow 2 questions. When you look at the program that you have, there is a QR code on the top right-hand corner. So that QR code is going to lead you to a folder where we shall put all these policies and any other information that you may require beyond what our panelists have told us today. So, Dominic?
Yes, thank you very much. The Master of Ceremonies. I'm going to give a comment, and my comment is on the barriers which we must address, which impedes accessing services by survivors. There are those barriers or delays in the community which should be addressed. There are those barriers which occur at police stations. At times you find filling that form takes long. We have the issue of the fees which survivors are asked to pay. In Ajumon, I've discouraged that. Any government health worker should not charge any money for seeing patients. We also need to address those barriers at the facility level, at the various levels. Right now, the police have employed health workers, but some have capacity issues. If a nurse is expected to examine a woman, most nurses cannot examine a woman. Even clinical officers have capacity issues in examining the survivors. So we really need to address these barriers. Then there are those barriers of the judiciary, which the lawyer said should be addressed. So we really need to, at our various levels, all the actors must do what is in their docket to ensure that the timeline the maximum timeline should not exceed 72 hours, so that we can give a package which will protect these people and prevent other diseases and infections. Thank you.
Thank you, Dominic. Just want to make a rejoinder on to what Dominic is talking about regarding the case management of GBV or SGBV. I think there is this kind of knowledge gap that I'm noticing when it comes to service providers. And we have been singing this song of ensuring that we coordinate the aspect of the case management right from the identification, actually right from awareness, identification, and then management, to ensure that that whole cascade is in sync when it comes to the client management. For example, you notice that when you mentioned about how we are getting cases and the police officer at the police station X has to examine this client for the forensics and so on. And yet the message we are talking about here under the medical legal approach, we are talking about a case, SGBV case, to first report to the health facility so that the health workers who have capacity to pick forensics from this client are picked very well based on the protocols that are already established, to make sure that this whole process is followed through using the established guidelines and protocols. So, and I was speaking to a meeting recently, the day before yesterday, on Friday. And this was a team of health workers who expressed a lot of ignorance about this. And this means that we need to do a little more in terms of, one, harmonizing what is supposed to be done, and then sensitizing for who the players in this whole arena is, in terms of what is supposed to be done where, who is supposed to do what, and then be able to help the client through the process to the end when the client gets justice and also gets the preventive measures. For example, when we talk about STIs and maybe unwanted pregnancies that comes secondary to SGBV, all that whole thing needs to be really solidified. And moving forward, it calls for allocation of some resources to do sensitization, to do capacity building of all the players, not necessarily only the health workers, but all the players in the arena, so that at the end of the day, we are all in sync in terms of what we're supposed to do to give the survivor, at which point, and then until the level of the justice prevailing, and then also healing and preventing those preventable HIV, preventable pregnancy, and so on and so forth. Then the other aspect, we have been talking about SGBV and skew our discussion to only the females. What about the ladies? I mean the men. I did not hear anyone mention anything to do with SGBV regarding the men. And yet you believe me, that this category of people are also suffering silently regarding SGBV and gender-based violence at large. So I don't know at what point shall we also lay emphasis on the men regarding this scourge of GBV. I want to end it here, but the discussion can go on and on.
All right, thank you very much. I think people have heard. Now, we have the supreme authority in SGBV with us this afternoon, Dr. Nakafero from the Ministry of Gender. So I suggest we continue the conversation after her presentation this afternoon. Is that okay? Someone is saying no. We shall still continue. It's still SGBV the afternoon. Thank you very much, MC. I think you come and thank us.
A round of applause to Jacobo and the team. Don't you think these gentlemen and ladies deserve a very wonderful lunch from? I think it's about time that we resume our lunch, after lunch sessions. You are most welcome back from lunch. I know usually lunchtime sessions and after lunch, they tend to be relaxed, and I can assure you that we are going to be very relaxed. Eric, these people, you had promised that you are going to play for them a video or what? This man said that when he saw me speaking, the voice was not coming, and so he needs to play it for you so that you hear how I speak when I am behind the camera. Thank you. As people come in, just see what we are building and what we are hoping to get over. I hope you have had an enjoyable lunch.
The silence around sexual and gender.
I am told, Rita, I am told the AC is making some of us freeze. But yes, thank you. You let me know, Eric, when you are ready so that... This will be the new home of the School of Public Health at Makerere University, the first institute of its kind in sub-Saharan Africa. For more than 70 years, the school has stood at the front lines of Africa's health, training generations of leaders who have fought HIV, Ebola, Marburg, and COVID-19. Their work has saved millions and shaped the future of public health across the continent. But today, our impact has outgrown our walls. We rent scattered spaces, stretching every resource to teach, to research, and to respond to the next crisis. That's why we are building a new purpose-designed home, a place for innovation, collaboration, and training of the next generation of public health leaders, because Africa's future depends on it. Right now, the continent has only 80 public health researchers per 1 million people, compared to a global average of 1,081. This shortfall threatens our collective health security. Every lecture room we build, every lab we equip, and every mind we train helps close this gap. The $10 million project is already halfway there, powered by, of course, the generosity of our staff, students, our partners like the Rockefeller Foundation, the US state government, NUFIC, plus, of course, many others. We invite you to join us in investing in the future where knowledge saves lives and where Africa stands strong on its own expertise. Because the future of Africa is its people, and their future depends on public health. Makerere University School of Public Health, building the future of health in Africa. think we shot too much time over and stretched over lunch. That was just to break the monotony of lunch and also coming into beginning the session. In case you are looking forward to charging, just behind and under your chairs, there are sockets, I have been told. But in case you find they are not working, we have some provision, or you can even choose to go somewhere up. Is Michael Wagawa in? You are most welcome, sir. We are going to have a quick session, which will be literally like the last session, after which we'll just go into a conversation of the reflections of the day, what we have just had a conversation on from the different discussants. And this is going to be a session, really a technical session too, that is going to be focusing on gender-based violence, or perhaps sexual and gender-based violence, like the previous moderator alluded to. We shall carry some of the conversations that we had and perhaps the questions to this particular session. And I want to take this opportunity to invite Michael Wagawa and Mr. Julius Muhwezi to come over. Michael Wagawa is a research associate in the School of Public Health's Department of Behavioral Sciences and Community Health. He's also, to the best of my knowledge, a PhD student, but also in many capacities, wears very many things. He's a mentor and also a colleague that supports very many people to see a lot more of things go. He's going to take us through this session with the presentation of students. It should be very short so that we go into the reflections of the day. Michael, the floor is yours, and Julius, congratulations. This gentleman is telling me that I did a mistake to come with the yellow things on the podium. I am taking them away, sir. Thank you.
Thank you, Davidson. Good afternoon. Again, my name is Michael Wagawa, a research fellow at the School of Public Health, Department of Community Health and Behavioral Sciences. And I'm going to take on this session. My colleague here is Julius Muhwezi. He's one of our students at the School of Public Health. And he has two presentations on SGBV, as we'll see later on. I also just want to say that on top of the introduction, I'm also an M&E specialist, and I've done some work, some M&E work, both in developmental programs and also humanitarian programs. And one of them, or two of them, have been in, again, humanitarian work with, I think, they involved AHA, still on SGBV and reproductive health. Oh, and I have to say it was really commendable because it was implemented by AHA and MESCO. But if we have some time, I'll be able to preempt a little bit because I don't think there was dissemination within this kind of audience. So to AHA and MESCO, kudos. So Julius Muhwezi has two presentations. The first one is on the prevalence and factors associated with delays in seeking post-SGBV healthcare services, and this was among survivors in Chakatu refugee settlements. And the second one will be on experiences and challenges that were then faced by these SGBV survivors who were delayed to seek the post-SGBV healthcare still within the same refugee settlement. And I think from consensus, do we present them at once or one by one? I would suggest we do one by one. They're not too long so that we can really have targeted interaction with each, and then rather than presenting them all at once. Would you prefer that? This is a democratic country, so I want to hear from you. Is that okay? All right, thank you. So Julius, again, is a student of Masters of Health Services Research, right, at the School of Public Health. And this is what turns doctors like him, his background is a medical doctor as well, but these programs at the School of Public Health turn doctors like him into superstar researchers in the areas of interest, and his area of interest is in SGBV, and he has also worked for over 9 years in clinical care, but attending to SGBV clients, and this was in affiliation to the Uganda Police Force Healthcare Unit. So he comes with vast experience, and then research comes in. So Julius, over to you. I would request you to take this seat so that you're at the center as you present. Is your presentation shared?
Good afternoon once again. My name is Julius Muhwezi, and I'm happy to be in front of you to present on what I like most. As a student of Masters of Health Services Research, I took on a study on prevalence and factors associated with delays in seeking post-SGBV care among survivors in Chakatu refugee settlement. I was supervised by Mr. Perez Ochanda and Mary Kacho. Next slide, please. Yes, just for formality, let me say that SGBV is defined as that violence committed against a person by virtue of his or her sex, forcing another person to do something against his or her will through using violence, coercion, threats, deception, or cultural expectations, or for economic means. And this is in the UNHCR reports. As you know, it's been overpublished that SGBV disproportionately affects females, and more so in refugee communities. So it's the reason why most of the data we have speaks to females, not that we discriminate against male. Globally, we know we have around 4.1 billion females, and 35% of this number, around 1.4 billion, have experienced SGBV in their lifetime, these females. In sub-Saharan Africa, at least 44% and 14% of women have experienced intimate partner violence and non-intimate partner violence, respectively. Back home here, at least one female in 5 has experienced some form of SGBV. And this is data that is available in the Uganda demographic and health survey data as published by Couch and others 3 years ago. The Uganda police in last year annual crime report indicated that 53% of the sexual assault perpetrators were HIV positive. And this means their victims were potentially exposed to contracting HIV infection. Next slide. The problem, therefore, is delay in seeking care that I'm presenting here, and this is what I've encountered in my clinical practice. The consequences seem to be obvious: HIV seroconversion on the top, of course, other STI infections, unwanted pregnancies, unintended, unplanned for, and of course, exacerbation of physical injuries. We thank you, the NGO community and the government. You provided this free medical care to these victims and survivors. Unfortunately, these survivors delay seeking for care, and this is what motivated my study. So, in a need for evidence-based programming, we need to know the prevalence of this problem, of this public health problem, and the covariates, the factors associated with this problem. Next slide, please. So, the first objective was to determine the prevalence of this delay problem by studying SGBV survivors who sought care at Bujumbura Health Center 4 in Chaka 2 refugee settlement. And then go further to determine the factors associated with this delay in seeking care in this population in Chaka 2. Next slide. Methodology. This was a secondary data analysis study where I reviewed the year 2024 SGBV register at Bujumbura Health Center 4. So this is the source of data that I reviewed that I'm presenting to you. Next slide. The far left caption is the first entry in January 2024 in this register. And the far right is the last entry in the year 2024, month of December, as the book closes. So the data is across the 12 months of year 2024. Next slide. No, you can go back, please. So in this register, it captures variables, including age, sex, ETC, marital status, and others like nature of the SGBV cases. But most importantly, if you look at column number 4, it has reporting. That reporting is still time zero. Time zero, no, reporting on column 4 is T1, time 1. That is the date and time when the survivor reports for care. And then column 18, that is the date and time when the survivor okay, thank you. So we have this column 18, date and time of reporting the violence. So this is when the violence occurred, and then, so the violence occurred here at time T0, and then the victim came for care to the clinic here on in column 4. So the difference between time T1 and T0 gives us the delay status. Next slide, please. So, like I said, the study was at Bujumbura Health Center 4. We had 456 clients in this, registered in this book, And then we have our time T naught, that is when the incident of SGBV occurred, and T1 is when the survivor came to the clinic for care. And then our outcome variable, which is delay status, binary in nature, we are having it as either the survivor having delayed seeking care or having sought care timely. If the time difference was found to be above 72 hours, then we classified that survivor to have delayed seeking care. And if the time difference between the occurrence of the event and the time of the survivor stepping in the clinic for care was less than 72 hours, then we were happy to say that was timely seeking of care. Important also to appreciate is our initial sample size estimation was 323 participants. But we analyzed the entire data in this register, and we had 456 clients, and this improved the validity of the study, making it more robust. Next slide. So results. I found that the prevalence of delays in seeking post-SGBV care at Bujubuli Health Center 4 in Chaka 2 refugee settlement was at 32.02%. In literature review, I found that my finding was consistent with another study done by Reynolds and others in the war-torn region of North Kivu in the DRC. Reynolds and others reported 30% of delays in their study, which they carried out at the Medicine Sans Frontiers clinics that they run in that region. So, and here we think that because the biggest population of refugees in Chaka 2 come from the DRC, followed by those from Rwanda and Burundi. So it is predominantly the same population with the same cultures. So we are meant to believe that we are working with a valid prevalence of delays in seeking post-SGBV care. Next slide. About the factors associated with delays in seeking this post-SGBV care, most of them were non-significant, but gender of the survivor came out significantly and indicated that there was a higher prevalence of delay among males. Males were 43% more likely to delay seeking care compared to females. The nature of case was also associated with this delay. And in here, having compared survivors who had been defiled and those who had suffered other SGBV cases, if you imagine that among the defilement survivors, when say 100% of those defiled were to delay seeking care, only 55% among the raped ones would delay, which means that being raped was better than being defiled in terms of seeking care. And likewise, we found that if 100% of defilement survivors were to delay seeking care, only 35% among the assault cases, survivors would delay seeking care. Referral pathway was also significant, and we see that if you were to have 100% of survivors being referred by the NGO community, all of them would delay seeking care. But When they are referred by the police, only 48% would lay seeking care. And when they are referred by the community, only 32% would lay seeking care. So, the team from the NGO world, the clients tend to delay seeking care when they have been referred by the NGO community. It appears that the NGO wants to do something, wants to do some first aid, wants to do some counseling, while they perhaps think less about the need to seek care within the first 72 hours. That's what we found from the data analysis. Surprising to me, I found that being a refugee was actually insignificant. Initially, I thought maybe that because they are refugees, then a refugee status would perhaps be associated with delay in seeking care, but it was not. Thank you. Next slide. So, in conclusion, we conclude that for sure there is high prevalence of delay in seeking care, especially among the males, and especially among the defilement survivors, and also those who are referred for care from the NGO offices, so to say. And of course, it means that many of these survivors are suffering consequences of SGBV, like we earlier highlighted. And most touching in this data, there are many children born out of defilement and rape incidents. Next slide. Recommendations. Friends, bosses, and colleagues, these results of mine are not generalizable. We seek that you support us more to conduct a more comprehensive and comparative study, this time involving data from all the 13 gazetted refugee settlements in this country. I want to believe that most of these refugee settlements have their main health facilities to the standard of Bujubuli Health Center 4. I want to believe that in your presence, sir, these SGBV registers are available in the main health facilities within these settlements. So we can actually do other studies, compare all of them, and then we can give you the national picture of delay in seeking post-SGBV care in the refugee community. Certainly, we need to have mind-changing intervention programs, especially targeting the males because of their known poor health-seeking behavior. And we appreciate you for the continuous training and awareness programs, but this time around, also to have the NGOs, part of the trainees, have the police and the communities to address these associated factors. I have to acknowledge, next slide, the support from the African Humanitarian Action, who funded my research. I appreciate my lecturers, Perez Chanda, Mary Cacho, and Namutuni Juliana, and of course, all of you partners here present, and the Refugee Administration, the OPM, who gave us permission, the camp commandant, the AHA staff who are here, all of you. You are supportive. The SGBV clinic team in Chaka 2, the two Okwares were very supportive. I salute you all. Thank you very much.
Thank you, Julius. Another round of applause for Julius. So that was Julius' first study. I'm going to request us to have some quick reactions, responses, and a few questions. And I think Julius will be in position to respond to them.
Yes, thank you, Julius, for sharing with us your findings. we have seen from your conclusion of the findings, delay in referral was highest among survivors who were referred by the NGOs. This may not be surprising. In Adjumani, the partner staff are reluctant to, first of all, examine these patients and even fill the police form 3. Because I think the policy of the NGOs is they do not want their staff to go and appear in court to give evidence. Also, NGOs, even their own staff, when they commit offenses which need this staff to be taken to police, they are reluctant. They just dismiss the staff. So I don't know whether, from your findings, whether this could be what is contributing to that delay, that the NGOs are reluctant to have their staff examine survivors, not only SGV, but even physical violence. We have had doctors in a general hospital who they would not fill the form, would get a government medical officer to fill the form. We have seen also that delay is second highest is among those referred from police. I don't know whether it is the process is there. But in Germany, we also noted that at times, parents will start to negotiate when both the survivor and the parents of the survivor and the perpetrator would come to police, and behind the scene, they try to negotiate. From your observation, I don't know what you think could have caused this second highest delay from the police stations. Thank you.
Yeah, thank you. Thank you for your submission. It's good that this was specific to Chaka. And when I hear Chaka, I know that's my home. So I pick interest a lot. In your submission to pick from DHO, the data that was shared was, I see it's mostly focusing on rape. I think it was rape related. Yet GBV has other forms. Was it only by design that you focus mostly on the sexual part of it? That's where maybe the focus was to MTI alone. I would want to bring to this house that the occurrences of these cases in terms of GBV are always informed by some trends. Currently, we are battling a lot with psychological, stroke emotional, giving the cope-up mechanisms to the economic situations and crises. And in that, Chaka actually has a linkage of 15 complete suicide cases. And per the standards, I think this is worrying compared to other settlements and the population covered. The other question, which is the last, you shared with us that, I don't know if I understood it right, that some of the delays are caused by partner referrals, given that the first one to venture into other services like psychosocial and others. I would want to know how dependable this information is, considering that the information we pass to community is actually to follow the 72-hour response. And usually before you intervene with any other response service, you first look at the risks this person is exposed to, if it's sexual in nature, by knowing when the incident occurred and how fast you can track to save a life by linkages to the health center. So I do not know if this came up from some key informant interviews or it was just a general observation. Thank you.
Thank you, Julius, for the research. It's good you have put a disclaimer that this is not generalizable, which is a good one, that it is only specific to Chaka Health Center 4. But when you look at, from picking it from what sister was talking about, whether this is coming because you were only looking at the two forms of violence, is why we are getting these very tall, can I say, numbers in terms of people who are supposed to seek care. And then at what level or at what degree are the people sensitized of where to seek care first? Because if we can establish that as per the guidelines, we always encourage that the survivor must seek care, health care first, because that's the baseline where you need to pick the basic things, the biologicals, the forensics first before you go to any other service provider point. And if probably the message is not sinking well by our colleagues, the NGO, maybe this is where we need to focus our energies. Because if they are doing that, then why would they be, again, the drivers to drive the delays? If they have the right information that people are supposed to seek healthcare first, and then again, when the delay is being measured here, again, they are the very people who are leading in the delay. So it's a bit controversial because they have this guideline that care is supposed to be first sought from the healthcare side before any other when it comes to SGBV survivors. It's a bit disturbing. But of course, moving forward, we need to maybe change the message or reinforce it by some way to making sure that as the survivors have survived from the incident of SGBV, they know where to run to fast so that that delay gap is closed. It's only then that we shall be able to, one, reduce on the incidence of HIV. And then, of course, the STIs that are associated with this, and of course, the unintended pregnancies that come as a consequence out of this. Just like you concluded, many children are born out of defilement and those other cases. But then the other aspect, part of the guideline that we have always been preaching the gospel, we do not have the responsibility as health workers to pronounce ourselves on these two terms. Rape and defilement are not medical terms. I don't know where we are getting these or where we get these terms as medical workers to pronounce ourselves on them. It is in the confines of the judge to pronounce rape, pronounce defilement. But I hear several health workers going ahead to mention these two terminologies. I don't know where we get them, but the guidelines are clear. We are not lawyers, we are not judges. Because defilement is a pronouncement of the judge. Rape is a pronouncement of the judge. For us, we are supposed to only take note of what we observe, okay, and then adduce that prima facie evidence to the judge to make that pronouncement. This is what the guidelines say. But I'm really disturbed by hearing people say defilement, rape. It's not for us as health workers. As far as I'm concerned, I want to submit.
One more.
Okay, thank you very much, Julius. I just have here a few questions for clarification. when you said delayed referrals made by NGOs, would you kindly elaborate the source or the tool that you used to determine the delay? For example, a case was reported today on Monday, but it was referred 1 week after. And there is some form of tracking that actually informs the delay of the referral. And then also in the humanitarian, most of the cases are reported late. Beyond, if it's health, if it's in line with sexual violence, beyond the 72 hours. And sometimes reporting to health may not be now a concern, but prioritizing the psychosocial support. So how would these cases that are reported come in late may not qualify for certain categories? And then the element of the survivor-centered approach and its guiding principles. How did your research incorporate these principles while looking at that particular element of delay access to care or services? Because when you say that a survivor did not, there was a delay referral by NGOs, our work is fully guided by the survivor-centered approach. The survivor takes lead. The NGOs are the ones that they inform you of the services and you make a decision. So if you have been referred to the police and the survivor says, no, I'm not ready for the police, then it is not forceful. You have to let them know. Once you change your mind and you find it is an option, then I'll refer you. What if the perpetrator is unknown and the referral to the police may not be an option because they are unknown or they are not in the country of origin? So comprehensively looking at all these factors before concluding, before coming to your conclusion. So, and then your recommendations on further areas to research on accessing data from the health facilities. My concern there is the ethical considerations. When we are handling issues of GBV survivors, it's not about the numbers. We are looking at human beings behind those people that we are handling. So the access to those data, would that be possible? Because ideally it should be with the consent of the survivors. And accessing survivors for academia may not that be easy because it's a sensitive area. So you could think through your recommendation because it may be a hard area to further research on. Thank you.
We're all done.
Julius, first stretch a little bit. Huh? It's okay. You're allowed to stretch. This lunch was heavy. The questions are heavy. We had a panel of over, 5 giants here. We got quarter the number of questions we are sending to Julius. Are you ready? Huh? Okay, I'll be here for your emotional support. Most of these were not really questions to you. Some of them actually were like kind of advisement, what should be done, so you don't have to really respond to it. And some of them are technical, areas that we need to consider, but try to focus on those that really need to be addressed. And of course, I request the rest of us, because like we said, he's only a student trying to master this area. So we can always chip in and react to the questions that have been raised. I will excuse myself from reacting because I'm just a moderator. So, Julius, the mic is yours. You have your own microphone there. Please.
Okay, thank you very much for these questions. I prefer to stand. Yes. Again, I have to explain this. That this is an SGBV register that is available at Ujubuli Health Center for right now as I talk. The data is in this register. It is for all of us. So, to begin with, about the source of the data that I used to present this result. This is secondary data that is handwritten and available in the SGBV register. This data was quantitatively analyzed using a statistical software, Stata version 14.0. What it gave me is what I'm sharing with you here. I hope that is very clear. It is data that was input into a software and gave me these findings. The next presentation I have for you may shed some better light on why we have these delays. Because the third objective was to explore the experiences and challenges faced by these particular survivors who delayed seeking care, whom we identified from our qualitative data analysis. So the primary study was an explanatory sequential study where you begin by a qualitative study, then you identify who the victims, those who delayed seeking care are, and then you follow them up and speak to them. I can give an example. There were defilement survivors who had never cared about the pregnancies they had, but their parents had taken them to the NGO for counseling. These were now coming to the clinic after 4 months, after 5 months. And when I review this data, I'm looking at when did this event occur? It occurred 4 months ago. When did this survivor report for care? It is today, 4 months ago. So in a data analysis, the software shows me that actually these survivors who intuitively needed psychosocial support came to the clinic because now they had to report this, first of all, also as a criminal case at the police. Then the police knows that they have the duty to have this victim or survivor examined on police form 3A. So that's how some of this data is coming. Now, I should have put maybe some of the limitations of secondary data are things like this, that some elements cannot be properly conceptualized through statistical analysis. It's one of the well-documented limitations of secondary data. Somebody comes at 7 months pregnant, but he tells me that for the last 4 months, he has been at Alight, for example, undergoing psychosocial support. In the register which I'm innocently reviewing, I see that this person was late by perhaps 360 hours or even 1,000 hours because the person is just coming now after 8 months. I hope that sheds some bit of light. So to look at the questions, number one was about the delays from the NGOs. The policy of the NGO is that, first is the survivor, and they have the right to guide you on what they want. That one I think I've shed some light. Then how about those referred by the police? Again, same explanation. Some survivors, especially defilement, in the next presentation, they tell us why they delayed seeking care. They are also taken to the police after 2 months when the mother has discovered that the girl is pregnant. So the police also plays their role very well by referring this person, this victim, for examination by the healthcare survivor, by the healthcare staff, who is in the SGBV clinic. So what does he record in the SGBV book? That the offense took place on this date and time, and today it is 3 months. The physical injuries, somebody made a comment on why the police also had delays. The next presentation explains, and there are quotations on what the survivors told me on why they delayed seeking care. The third question, rape and other forms. Yes, the question was about, I seem to present only rape and physical and defilement. Again, the disadvantages of secondary data. The SGBV register does not cater for all the other forms of SGBV. Not all has been catered for. Okay? So what I was able to pick is what I presented to you. The pattern and referrals, that analysis that I've explained. About the question from the Minister of Health, what degree are the people sensitized? Survivor must seek care first. I've explained NGOs, driving delays. I don't want to commit that NGOs are driving delays, but what the statistical software analysis shows is that victims who are the relationship between survivors being referred to for care from NGOs, which of course is a very good thing. We are reporting after 72 hours of the occurrence of the SGBV case. The issue of whether healthcare workers should report rape and defilement terms, I would be advised on this. I'm not so sure, but what I know is that the innocent healthcare worker in the SGBV clinic receives a form from the police, and the police clearly indicates the kind of case that it is investigating. Okay? So the police will indicate on that form the kind of case that is investigating. Maybe the police says we are investigating a case of defilement. We're investigating a case of rape. So in the SGBV register, the healthcare worker also reports, and in one of the columns under remarks, what kind of case he was examining, depending on what the police has indicated for him, because all these police forms, they come from the police with duly stamped by the police officer, maybe the investigating officer. So that's how these terms come to be associated with medical workers in the clinic. So a question from the UNHCR about the reference source of the delay result by NGOs. Yes, it is from the SGBV register, because the SGBV register has a provision for the healthcare worker to indicate who actually referred this survivor to the clinic, and that's what is available. Service-centered approach, yes, we appreciate, yeah. I mean, it's all about the survivor. That one I explained. Data concern, data is available in the SGBV clinic. Again, this one you may have to guide me on this. I don't want to commit myself, but I think as the NGO community, as government, I think you need evidence. It's our data, it's our work, it's our responsibility. So you have to guide me on how this can be done. I'm happy that there are many senior people here who can guide on how this can be done, but I'm sure that you need evidence, evidence-based programming. So I think those were the questions. I could proceed to the next presentation.
Not so fast. Please take a seat. Have we, Jacob, we have something? There are more hands up there. Okay. As we get 2 more hands there, I think for the data concern, we also, I think we referred to, because you said further exploration and further studies were required, but then this data, the way I understood it was to do with if you're to use questionnaires and you to talk to the victims themselves rather than using the secondary data, which you already see that is already flawed, since there are so many questions that came up due to the secondary data. So if you're to roll out a fully fledged study, then that means you're going to have to talk to the victims themselves. So the question here is, will you be able to access them since it's a sensitive area? I think that was just the guidance that she was trying to give you.
Sure.
Yes.
Okay. Thank you. Colleagues, now speaking to my colleagues in the implementation field. The students are master's students, and they were using the data that we have either generated or the data that they were able to access from the people, the primary data. The data that his was from the records that we have in the health facility, as you saw. So if that data is speaking something, yes, we need to find out why. That should be the direction we're taking. It is not a bad thing that the referrals that are being made by the NGOs are 100% late. In any case, it is good that the ones of the community have not appeared there, because those are the ones that we want to be worked on immediately, isn't it? So, but the issue is with us, we receive so many. You'll actually realize that even in the NGOs, we get clients who the incident happened in the country of origin. Yeah? But you're not going to ignore it. The health facility is not going to ignore it. Does not matter what time it is. They will report it. But in the register, they will write, where is it coming from? Alright. Where is it coming from? Aha. They will have to indicate the source of the information. Police, the same. I saw what? There's a third one also. So the data is there. So the question we should be asking ourselves is, what is it? What is the challenge there? Accept the data. It's scientific. I know that.
Okay, thank you. Allow me to clarify, not asking questions. You did ask for some guidance. And GBV work is quite sensitive, and especially when we are working with GBV survivors. Now, the data that we do have and we should use should be non-identifiable data or anonymous data. The first interaction we have with the survivor is what we call a consent form. And when you're ticking that consent form, confidentiality is breached for service provision. And that's the primary role of every service provider. And secondly, we also tick the survivor can consent that you can use their data for maybe advocacy, and that's the final data that you will see. In the instance that you've explained that well to the survivor and they do not want you to use their data, you will exclude that. Now, when you're talking of the SGBV registry at the health facility, and it's something we can clarify, but it could also be the antenatal. We have the partners that do antenatal screening that also come for every young girl that goes to access services for antenatal care, they will register them because they do the antenatal screening. But then the element of disclosure is not easy. Being a survivor of GBV is a very traumatizing incident. And let's stop looking at the survivors. Bring it back to yourself. Imagine you were raped today. Would it be that easy for you to run to someone and tell them that this happened to me, I need help? Most likely you're going to think over it. You're going to be traumatized over it. You're afraid of the stigma. You're afraid that someone will not keep the secret. And that's what people who go through GBV experience. And by the time they disclose, sometimes it's too late. A research by Refugee Law Project shows that many survivors of conflict-related sexual violence, many of them disclose their incidences after 4 months or 6 months. When they are still new, in a new environment during the emergency, they are settling in, they are not sure, they are learning language, they are learning the environment, but also the experience of being a survivor is that hard. And when they disclose to anyone, as service providers, we should be able to link them to the other service provider, explain the services, and be able to link them. So that is a process. There could be challenges with partners referring cases across each other. But internal referrals could be working well, and that's an area that partners can improve, and it's something that we discuss in the coordination. So your topic is very good, however, very, very sensitive. Accessing survivors ethically is an issue and not right, because it's not about academia. We should be accessing them for service provision. Even for our work, even if we are giving them livelihood, we are not going to put their faces on the report that we gave them a support and now these are their faces, they are doing well, and to get more money out of it. But then these are things that we continuously talk about, but accessing of survivor information, by the fact that from the beginning they have consented to only give non-identifiable information, we shouldn't be going that far to meet the survivors. And there's still more to learn, but we also appreciate your work. There is more to add to it. Align your research to the guiding principles. When working with child survivors as well, there are also ethical considerations when interviewing survivors. Sometimes you may not even interview a child survivor for academia, but should be in the process of giving them services. So that is just a brief clarification that I wanted to give. And then Doctor has also talked about when a survivor has when a rape case, who should the survivor report to first? When we are doing a training with health workers, they will be saying the health point should be the first point the survivor should report to. When you're training and the house is full of the police will say, no, it should be the police, the first that you should go to. When it's humanitarian, they'll be saying, why not come to me? I'll go and refer the case. I'll escort you to the police and to the health worker. But the message is, we do not have control as to who the survivor will disclose their case to. But when they disclose their case to a health worker, they will provide the medical treatment and counseling and link them to the partner that provides psychosocial support, and then the psychosocial support will also link them to the legal partner if that is needed. all this is driven by the survivor-centered approach, explaining to them. So the survivor can approach any service provider, and as service providers, we are supposed to see is health, prioritize safety and health. So if it's within 72 hours, prioritize safety. If there are elements of safety risk, prioritize that within that period when the survivor has come, and then be able to provide ongoing follow-up and support. So I hope this clarification also helps. Thank you.
Thank you. One more?
Yes, thank you. I just wanted also to do some clarity or to maybe also direct my colleague. I think if you have collected, if it is a secondary data, we expect at least what is mentioned there. It's mainly maybe the patient came from a partner or they came from a police. I don't think if what is documented there will communicate whether maybe this patient delayed or how long the patient took with the partner or with the police. But what we are doing there is, I think we are doing standard things. What she has said is we always coordinate. Like from Bujubuli, we have a one-stop center where allied, TPO, and medical teams are supposed to sit there. So when a survivor maybe reports to allied, if it is within 72 hours, we know the standard. This client has to be escorted to the facility, given the first aid that is needed, and then also referred back to the protection team to make sure that they take over what they're supposed to do. What I know is maybe you need to try to, I think, change it maybe from delays with the NGOs, but should be like those ones who report. Most of the time they report through NGOs, like the partners who are supporting. Mainly these partners have a service point within the community. So they are the first people to be to get into contact with this client. And immediately they communicate. If it is within the 72 hours, most of them have been escorted to the facility, examined, and then referred back. But those ones who are now beyond 72 hours or beyond 120 hours, as per the standard, most of the time they need psychosocial support and then other services which are needed, especially maybe the police and the law. That is what we always do. So I think in the register, it's just stated maybe was this patient referred or not. I think maybe you need to check on that. Thank you.
Thank you, Doctor. Before you hand over the mic, you're in charge of the Bujibuli, right? Health Center.
Yes.
I've been there. I know it's a very big facility. Yeah. So allow me sacrifice you on behalf of other health workers in that facility and other settlements. There was a question that was raised about the pronouncement of rape and defilement, and this is what is in your records, right? So I just we probably want clarity, or could you clarify on how we get to record that in those records of yours? Do we get police reports or someone reports that I was raped or defiled? Please throw some light.
Yes, thank you. Our register only records the type of GBV where we have physical and sexual. That is what is reported there. But what I know is like when people are picking data, they look at the age category, and then also on the police form, as he has already mentioned, the police form always tries to direct you towards something. Yeah, but what we report in the register, and my colleague I think can also verify with that, we have only physical assault and then sexual assault. Mainly that. Thank you.
Thank you so much. I hope it's been a learning point for all of us. Let's just try to pick out as much as we can. So in the interest of time...
There was only one.
Yes?
One person was trying to share. I don't know
Okay,
if you
could
can
we
take it
like wrap it up within a minute and not really...
summary?
Yeah, thank you.
Thank you, Julius. I'm Richard Mulumba, also from Chegegwa. I'm curious about one or two things. I don't know whether I heard you right when you said that being a refugee was not statistically significant in relation to the delays in seeking for health services. And if so, what did it make of you? How did you understand about it? Or probably, did you try to compare with the non-refugee community? Of course, you didn't tell us exactly how many, if you are looking, because that Bujubuli hosts both, rather attends to both the refugees and non-refugees. So among the clients that you reviewed in the books or registers, how many were from regional refugees and how many basically non-refugees? Probably the ratio would see where it lies. Maybe as much as you analyzed it, showed that it was the refugees, not something that you never know, even the host community, maybe it was not. And if so, you must have probably some hypothesis that maybe being a refugee would have been statistically significant. If it has not come out like that, as much as that is data analyzed, what do you take? Because this is going to affect you in the near future when it comes to discussion. Two, when you look also at, I don't know, because this thing now, as one of the moderator, rather, the discussant brought about ethical issues. So through your clearance of IRB, I don't know whether they put this into their consideration, because it seems like your study is still ongoing. Otherwise, it may not really be clear. Then thirdly, the entry point to the district. Yes, I appreciate you talked about the Bujubuli community and so on. But the district, because Bujubuli belongs to the district, did you manage to go through the right channels before you reached the point of data collection? Maybe you clarify that, because we need all those documents when you publish it. Thank you.
Thank you. I'm glad actually you raised that. That's the only question I had from the presentation personally. Your first question about being a refugee, the refugee status not being statistically significant. How did you come up with that? What implication does it have? Was your study powered enough? But yeah, so that. And the other two questions could be maybe points of advisement about ethical issues and the entry, which I believe we got clearance from the OPM and the rest. So that, but then this other one, please attend to that. Can you use 2 minutes?
Yeah, thank you very much for those questions. Yeah, the first question was about the refugee status not being significant. Yes, in the statistical analysis, the majority of the survivors who died seeking care were refugees. I think they were around in a ratio of maybe 1 to 3 quarters. So majority were refugees. But the status of being a refugee in that community did not significantly contribute to you delaying to seek care. So while most of these survivors of SGBV were refugees, and while most of those who also delayed seeking care were refugees, in terms of numbers, but being a refugee as per status, even if it was associated by you delaying to seek care, it was not significant. It was not significantly associated with the outcome. I don't know whether I've been able to explain. Many of the survivors were refugees. Many of those who delayed seeking care were also refugees. But in statistics, in terms of these facts, because these are variables, these are factors, in terms of the factor of being a refugee causing one to delay seeking care was not significant. Even if there was an association, but it was not a big deal, so to say, in simple terms. It was not a big deal. The adjusted prevalence ratio was not significant. And the confidence interval, the confidence interval was not, it was not a big deal. Don't want to say big things here. Yes, so there may be a relationship, but there's no cause for worry, so to say. My seniors are here, maybe they could shed some more light, but that's what I can say honestly. Then the question of, yes, about clearance for this study. I'll just say maybe 3 words. Well, number one, we were cleared by the research committee, the Institutional Review Board, which recommended us for more clearance from the office of the OPM. So the OPM gave us a written permission to conduct this study. And that written permission was taken to the camp commandant, who received a copy of the same and also cleared it. So we followed all the procedures. The IRB at McKay University, the office of the Prime Minister gave me a copy of that letter, taken it to the camp commandant, and everything, all the procedures were followed. Yeah. I did not go to the DHO because from the OPM, they copied me to go to the camp commandant. Yeah.
All right, thank you. I know there's so many questions probably, and I just want to request us to wrap this first presentation up about the statistical significance and the results. I think there is a lot more there that needs to be discussed because I think all I had was you mentioning the same thing, but then the content, the nitty-gritties of how it should be, the power to allow you to compare two different groups. It was one, did one have enough sample size to be compared to the other? Now that you're saying one was dominant to the other. So they're trying to bring out those, but those are things that you can, think about as we move on. But all in all, it was a good study. And I think the other thing to pick from this, because the question is, how did you establish that the NGOs have more delays or created more delays? What other delays were within the delays there? This underscores the need for, I think, mixed methods research because we get so many explanations in there, right? And the next bit is qualitative, and we'll probably get a couple of answers about that. Then I'll allow you to respond. So, Julius, I'm going to request you to give us your next presentation, and this is a purely qualitative section or part of the study, which is on experiences and challenges faced by SGBV survivors who had delayed seeking post-SGBV healthcare, and this is within the same Chaka refugee settlement, right?
Yeah, thank you.
It's all yours.
Thank you very much once again. So we were discussing the first 2 objectives, which were to look at to answer the question of what is the prevalence of delay in seeking care, which we took as a public health problem. Then we answered the question of factors associated that I shared with you. And then objective 3 was to explore the experiences and challenges faced by these people whom we identified during our qualitative statistical data analysis to have sought care after 72 hours. Next slide. So the problem statement, is that there was delayed care seeking among certain group of survivors. We fear about those consequences. We know these services are available. We know that the communities and the NGOs would wish to have programs, the intervention programs tailored to address these barriers that are associated with the delay in seeking care. But the challenge is we need to know from these survivors who are seeking care exactly which experiences and challenges they have faced that led them to delay seeking care. Next slide. So that was the objective, to explore the experiences and challenges faced by SGBV survivors who delayed seeking care at this health facility in Chegegwa district. Then next slide. So the design was an in-depth interview study, and the IDI participants are those survivors who were identified to have delayed seeking care. I interviewed 20 participants, and these participants were conveniently sampled, basing on reachability, being able to reach them, and their availability and the consent to participate in the study. We had a female employee of Bujumbura Health Center 4 who helped me during the IDI interviews do the translation. And yes, please. Next slide. So from the in-depth interviews I had with these survivors, they brought out factors or barriers that were in two kind of themes. Most of the factors or barriers were community related to the communities where they come from. And the other group of barriers were to do more with the health care system available. Now, under the community-related barriers, some were family-related, others were financial, others were authoritative and bureaucratic in nature, seeing delays happening at the police, the traditional norms in the communities where they come from, and even at the LC1 level systems, and also the social pressures in these communities where the survivors come from. Next slide. Under the family-related barriers, over the theme for community-related barriers, majority of the defilement survivors, whom I'm calling children, they reported that fear of their parents' reaction is what led them to report late for care. A survivor number one, a rape survivor, shared that she feared to inform her mother because she thought her mother would start shouting and blaming her. And that eventually, when the mother kept probing and she opened up, her aunt and the mother eventually took her to alight. And so she explained that had it not been for the initial fear of being blamed, she would have perhaps opened up much earlier. And the support that the mother and the aunt gave her after opening up made her feel that it was the fear of her parents' reaction that was responsible for her delaying to seek care. Most of the defilement victims and the young ones indicate that it is the fear of their mothers, of their parents, that caused them to eventually delay seeking care. Next slide. Next slide, please. This was also a painful experience. This was a housemaid that was raped when she had gone to fetch water. And that she did not know where the facility was after being raped. And when she told her boss that she had been raped, she asked her boss to escort her to the health facility, but the boss refused. Next slide. So lack of guardian support came up. Next slide, please. Then in the community where the police lives as well, there are also delays happening there at the police. And most of the cases about the police were about police forms. This survivor in particular, she said she did not have money to buy police forms. And eventually she was told to go and buy them from the photocopier. So she came back with the money on the third day, bought police forms, and then came for medication and feeding of the forms on the fourth day. Next slide. Social norms were also seen as barriers to timely seeking of care, especially those norms that were authoritative in nature within these communities. A survivor shared that for them, as the Banyamulenge clan, they first report these cases to clan leaders. The clan leaders have authority to handle some of these cases, and they want to sort of those matters. It is only until when they have failed that the survivors can now seek care outside. And according to her, this makes this authority that the clan leaders hold in the community makes some survivors delay seeking care after they have been raped. Next slide. This was about a physical assault survivor. He explained that the reason he delayed seeking care is because he had been arrested and kept in police cells at Bujibuli for 9 days. And as soon as he was given a police bond, he reported there at the clinic for care because he had pain all over his body. He said he was arrested because he fought with people who were beating his wife. So these are authoritative factors in the community out there. Next slide. So you can see that now delays were also from the police because when they arrest, they may not care much that you need to seek care within the first 22 hours because their interest is to investigate their case. Then there's stigma, shame, and discrimination. These survivors shared that in society, pressure in the society, that when a girl or woman is raped, going to health facility opens up secrets. And that discrimination comes in a way that if you've had friends, they no longer want to be with you because identifying with you, there is fear that the public will think they were also raped with you. So in a way, that deters rape survivors from reporting for care in time. Next slide, please. Then the health facility factors were mainly structural and about distances from the health facility. And issues of transport kept coming up. This survivor said that the hospital is far, didn't have transport money to pay for the motorcycle to take her to the hospital, that she was feeling weak, the hip joints and private parts were aching, so stayed home and allowed to have some bit of, first get some bit of energy. The process factors were again coming up to do with referral systems. This survivor said that first went to report a case to the police where a day was spent. The police later gave the forms for the doctor's fee, but the clinic had closed by that time and had to return the next day. Those are to do with the referral issues. Next slide. Then there are also individual barriers. A young survivor mentioned that she feared going to a health facility, apparently because doctors would laugh at her and say that when doctors know my age and later hear that I have been raped, they will laugh at me. Yes, she said, yes, I fear doctors laugh at me. She answered, she repeated it. A young girl engaged in sexual intercourse. So finally, next slide. So we conclude that in this community, family foundations are key because most of the adolescents kept bringing up the issue of fear for their parents' reaction. Financial barriers also came up a lot to do with an affordability of transport fares to health facilities, and then the cultural norms and pain-free the misinterpretation of authority by the LC1 and the police affected timeliness in healthcare seeking. Next slide is to really to appreciate you, the AHA community. Oh, recommendations. Yes, again, I mentioned that this study is not generalized, not generalizable. We need to do more studies, at least involving the 12 other gazetted refugee settlements. So the NGO community, of course, continuous community health education about the need to seek timely care and parenting sessions to be involved, to be included in programming, awareness sessions to improve child-parent relationships, and then awareness programs targeting the police and the LC1 systems. And of course, the government to improve on the funding, to improve on the patient waiting time, and also training to improve on the healthcare workers' attitude. Lastly, next slide. I appreciate you for the funding, the AHA community, and also appreciate your partners, and to my research supervisors, and Refugee Administration, Office of the OPM, Camp Commandant, and of course the AHA team in Chaka and the SGBV clinic at the Refugee Center 4. Thank you very much.
Thank you, Julius. Please have a seat. It's always good, it's always a prudent thing for you to have a seat. You realize now it's good for you to sit. Before you wanted to stand, but now it would be better you sit. People are coming. Thank you for being attentive, and thank you for, I know you're warming up. I've noticed a few things. There are the same things keep coming up, same ideas, the remoteness, and actually in the M&E, the evaluation that we carried out in Chaka 2 in that Better Life, Better Health project, we realized that they, AHA and MESCO had done a very good job. However, there were still some gaps in the remote areas. So when you talk about structural barriers, distance, and transport, still really these things, I don't know how we'll handle this good enough. Our big people are here. We probably need more energy in this. So you might be saved by the angel of life. Davidson, let me invite Davidson to take on this session with me and another colleague, and we'll have a joint Q&A session, which might be a bit more interactive, and we'll have some experts on board to help out with this. Thank you.
Thank you, Michael. Colleagues, as you have heard, beyond the money will come. Points are coming. I saw questions and you nearly took the man to prison for very many questions. And I think it's very important, those of you who are thinking about research, to start thinking openly about some of the feedback that we get in such forums, because they help us strengthen and bolden our move. Tomorrow when we become researchers and we want to defend our work, it really appeared like a PhD defense. But thank you so much, Mr. Mwez, for even keeping a smile when I saw you. So, after lunch, I just peeped around and I saw some of you a bit trying to lean on chairs and trying to think about probably the next day. Maybe we could just stand up a bit. Let's stand. We could stand and then stretch a bit. As Mr. Mwez enjoys the seat, I'm going to request Dr. Nakafero, Angela, to be coming through to just share with us from the Ministry of Gender about what she thinks about already so far what has been shared here, and also what the Ministry of Gender is doing in the aspects of protecting beyond the refugees, also the population as well. Lucia, you had said that this is the right time for you to give us some stretches so that we see how you know how to do it. Yes, thank you. You want to get a mic? Okay. Thank you so much. Before we go to the final reflections of the day, ladies and gentlemen, allow me invite Dr. Nakafero to give us her views and thoughts about sexual and gender-based violence, but also do not forget to speak to us about what you think about protecting the dignity of refugees in the country. You are most welcome, Doctor. She deserves a very powerful round of applause. Thank you so much, Doctor, for gracing this occasion. Then, I don't know, after, if you want to join the hot seat, we will be glad to receiving you. Thank you.
Thank you very much. I want to stand on the existing protocol. My name is Akumo Christine Okot from Ministry of Gender, Labor and Social Development. Dr. Nakafero had an urgent issue that she had to deal with and decided to send me here some few minutes ago. But because this is an area that as Ministry of Gender, we are very concerned about, and it's in our area of focus, one of our thematic area. That's why I thought it would be very important to come and join you. Gender-based violence or sexual and gender-based violence is is a health issue and also a human rights abuse, as most of the speakers have been alluding to. And is one of the underlying causes of inequalities in Uganda and poverty. Looking at our National Development Plan 4, it's stipulated in it that it's one of the causes of inequalities and poverty in our community. And it's also deep-rooted in our social, cultural norms of the different communities we have in Uganda. You'll find that the norms give them what is expected of a man, what is expected of a woman, and somehow when such powers are abused, then we see violence taking place. We are saying that it also it has greater impact on women and girls, but we say men are also victims of violence, and we can't undermine that because men also undergo violence. So we need to talk about it. It affects people irrespective of their social, economic, and political status. We have seen political leaders high in positions who have undergone violence. We have also seen in various women who are educated undergoing violence. So it doesn't matter where you are from, whether you are educated, you are poor, violence affects everybody. And it has a great effect on our mental health, our physical health, and so many, and even emotional health. If you look at the survey of, against violence against women and girls, reveals that over 95% of women are reported to have experienced physical and sexual violence since the age of 15. So throughout their life, they have experienced violence. And that is what the survey states. And that is the reason why Uganda takes it as one of the key priority area, an area that we need to focus on. And it also states that over 16.7% of women and 5.6% of men have ever experienced sexual violence since the age of 15. So we are saying that it's even boys or young men experience violence, sexual violence. It's not only women, but as he stated before, statistics inform us and evidence inform us that women experience that more than men because of the social cultural practices in our community. We have that survey also stated that the Bukedia region is highly affected by intimate partner violence with over 48%, followed by Acholi sub-region with 47%, and then Elgon region with 33%. Although other areas, there are statistics in other areas also, but these are very high, these are intimate partner violence, people who have been in relationship. So that means that it's a big concern in our community and it needs to be addressed. As Ministry of Gender, we have various programs related to, in response to gender-based violence. We have, first of all, we have policies currently that we work with that helps us in response to gender-based violence. We have the national we have the national gender-based violence policy that of 2016, violence that of 2016, that talks about violence, and it also talks about what are the key principles that we work with, what are the key referral mechanisms that exist in the community, and how we can either respond or prevent violence. It talks about that. We have also an action plan with it, and that action plan was developed not only by the ministry, but all the partners that we work with on what to do and how to respond to gender-based violence. We always say that where it's a defilement case, where it's aggravated in nature, where it involves threat of life, health response should be the first. The rest should follow after that, and that is one of one of the areas that we focus on. We said health response, especially where the life of a person is at risk. We need to go there. Although before, people used to say that, okay, the police, you need to first have the police form. Even the health personnel will not work on that. But we agreed with the health, Ministry of Health. We also agreed with the police that the life of a person is very important. So we should work on that. Ministry has also realized that ending violence is not something that Ministry of Gender can do alone. And not only that, it needs everybody. And then we have this multi-sectoral approach to ending gender-based violence. Currently, we have a medical legal committee that work with, the chair to that is the ODPP. And then the co-chair is the surgeon, the police surgeon. And then Ministry of Gender is the secretariat to that committee. And that committee meets regularly, on quarterly basis, to ensure that issues that come, issues of delay of access to services are addressed, whether in health-related delays, whether police delayed, so that we come out with guidelines to help that. And it has been working, and I believe that some of the guidelines that the health Ministry of Health came up with came as a result of that medical legal committee. The ministry also has a gender-based violence reference group that pulls all partners, academia, it pulls CSOs, everybody, and they come together to look at issues that are in our communities, those challenges that he has been putting across, and try to see how do we go about to address some of those issues that come out, merging issues that come out from, the work that we do in the community. So that is also one of the areas that we work in. The issue of engaging men, we said male engagement is very, very important. Many times we look at them as perpetrators, but we believe that with them, if they get in and appreciate that gender-based violence is detrimental to our health, and it's also a cause of, all these other economic issues, then they can, if they come in to join us and say it's a bad thing, it's something that should not be practiced, we need to avoid it. And that is why we came out with a strategy. Not only Ministry of Gender, even Ministry of Health came out with a strategy on how to engage men in all the GBV prevention and response activities within the community. We have worked on policies on teenage pregnancy and out-of-school sexual education. We have worked on some of those policies. How do we help our community? Knowing that in the community, when a girl turns 13 and 14, they start looking at them as potential wives to somebody. How do we help change the mindset of the community? We are working with community cultural institutions, religious institutions, cultural institutions to make pronouncement on such issues. We have programs that we work with. Currently at the ministry, we have programs like the UN Spotlight Initiative program to end violence against women and girls and sexual reproductive health issues, rights. And we also have the UN Joint Program on eliminating gender-based violence that we are working on. And then we have another one on ending female genital mutilation. Government of Uganda gives a lot of money to institutions in the Sabay region and Karamoja region to combat female genital mutilation. And of course, you also know that we have laws related to that. We have the Gender for Development program targeting adolescents in schools. How do we help adolescents? How do we help them with life skills? How do we help them be able to prevent violence from happening to them? How do we make them more assertive and state no to be a no? We are working on that. And based on my comment on the presentation that was given, yes, those are realities we have in our communities, although we need to go further and interrogate the lateness by partners, because I know many times, as we stated, when a survivor report, it depends on when the survivor report, immediately services are good for that survivor, and immediately if it is health, we seek survivors are taken for health. And with the report that we have from the various partners, being the fact that we coordinate this program, the reports are very clear when it depends on when that survivor report. So if the case is talking about 4 months after the incident, sometimes the incident might have happened either from the country of origin, or sometimes because of the socio-cultural practices within the community, the culture of silence, that is making it very difficult for people to report. Or, of course, some of the reasons he gave in. And of course, we are also still battling with the issues of police forms. Whereas some police posts have understood and appreciated that, you need to provide these forms free of charge. And we have also tried to provide those forms in some of the police stations. Some still sell those things, and our communities, some of them are so vulnerable that they cannot actually even buy a form, because sometimes they're selling you at 5,000, 10,000, in some places even 20,000. So that is one of the challenges we have been discussing and debating. How do we actually bring that to a stop? In some districts, we have even given photocopier machines at the police stations so that these forms can be, photocopied and given to what? But you will find that sometimes that photocopier is used for other things. So those are some of the challenges that we still we battle with. In some places, it's reducing. But also the challenge we have currently is that although we are doing this, most of our fundings are donor-related funding, except for the health, some of the health services, and some of the police work that they do, although we also support the police work. And these services are, for example, currently we have about 175 districts in Uganda, districts, cities, and municipalities. But you will find that our program is in about maybe 50 districts, not even half of the districts that are in Uganda. And then when you see where they said GBV is very high, or in maybe these districts, probably the reason why they're saying it's very high in those districts is because the people in those areas are aware and are reporting. And probably in those other areas, there are few interventions or no interventions, so they are not aware. The culture is still being practiced. The culture of silence is still being practiced. So currently we are actually working with government of Uganda. We are trying to lobby government of Uganda to give us a program for GBV, prevention and response. Otherwise, if we are to rely on donors alone, then it will be very hard to prevent gender-based violence in the country. I think I need to end here. I didn't really prepare myself. They told me go, then I came. And of course, when your boss tells you that, whether you are ready or not, you have to be ready. And I had something to share with you, and that is what I can share for now. Thank you very much.
Thank you so much, Doctor. Good enough, your presentation came right after lunch. I would request us to raise that a little bit higher. I would request you to have a seat as we wrap this up. We are not going to have another hour or so. We're just going to have a few minutes as we wrap this session up. We have reactions and a few questions and a few recommendations. I need to hear what our take homes from today's. But at the same time, as we focus on the presentations from both Julius and Doctor, as well as what we've had today. So in other words, we are wrapping it up, and we can always use these two wonderful people as our reference points. Any reactions from the audience? We can move the microphone around. Thank you. We'll start with Jacobo, then Jacobo, then there is a lady here in pink, then a gentleman with the Mercedes Benz hat or cape. Yes, Jacobo, please.
Thank you very much. My question is to Ms. Akelo. You mentioned that you've had a meeting and you deliberated and you came to a conclusion that yes, when something happens, when you have an incident of GBV, the initial point of care would actually be the health facility. I don't know, I would like to get some initial bit of guidance. From what I've been informed, in case that particular survivor would want to eventually take the case to court, asking naively, just to be clear, wouldn't it be important that as the medical team is doing their work, there is already a police case registered? What do I mean here? Because if she goes to the health facility and all of that is done, and it's not done on a proper form, and then they eventually go to the police, a form is given, they would have to go back to the health facility for another round of being checked. Thank you.
Thank you, Jacobo. Just remind us, we have less than 15 minutes to close this up, so let's keep the questions brief.
Thank you, moderator. My name is Warugembe Robert Sandy. I am a community activist on GBV working with the AHA. I reside in Kansanga. My question here is, we are told that we have 1.9 million plus refugees in Uganda. One might assume that all the refugees are in refugee settlements. There was those ones who were happy, very lucky to get refugee cards from the Office of Prime Minister. I want to know what is the number of refugees in refugee camps and those in our communities. The second thing, Madam Lydian talked about mental health in refugees. Where I reside in Kansanga there are very many refugees, Eritreans,
from DRC. They smoke marijuana, shisha, that can cause, I think, their mental health. Thank you.
Thank you. Can we have one or two more? Please keep Davidson. I don't think he has anything to say.
Thank you very much. My question goes to Julius. It's not actually one, they are quite a number.
Make them brief, please.
I will, Doctor. So my first question is, if the first study, actually, if the second study was anchored to the first study, and you did, the findings you got revealed that implementing partners did delay the referral, why didn't you interview them in the second study? That is the qualitative one. Then the other one is, how did you identify these victims? Then the last one is, during the interviews, you did have translators. And this is quite a sensitive topic. Into the presence of the translators interfere with the openness of the survivors. Thank you, and over.
Thank you, Esther, for those technical questions.
Just to supplement on our question, this is Joshua from Jesuit Refugee Service. When you're interviewing the survivors of GBV, it's a very sensitive part. Did any of them break down? And if they did, did you have counselors to support you? Because that's a very sensitive part. And according to the way you're responding in the quantitative studies, it sounded that this is something you should have looked at.
Thank you, Joshua.
Yes, I think the questions are done.
The questions are done.
Yes.
Okay.
I only have Davidson here. But Davidson, you have a mic to yourself after this. So maybe we can keep it.
Mine goes to, my name is Theo Teta. I work with AHA, a medical coordinator. Mine goes to the Ministry of Gender. I think, like you can notice, there are many actors in the space implementing GBV, and the approach to the referrals in this space is not well streamlined. So I wanted to find out if there are efforts to streamline referral pathway and whether it's actually in the pipeline so that maybe it's expedited. We know from community where next, after that, where next. Otherwise, we are so many. This one takes there, this one takes. And within that, our researchers are finding out that there is delay in offering some services. For us in medical, we need the first 72 hours to interface with survivor to be able to rescue or save the situation. So,
David, he has a question.
Thank you. Mine is just a comment for all of us to reflect. From the researcher, we have had issues around police form and the cost involved. And we have also heard from the technocrat from the Ministry of Gender speaking also about engagements with police, about also similar things around the forms. As the audience, what do we make of the forms? What is it that we can do to make sure that the forms are available? Do we say that the police is never funded to get these forms available? Why is it that they are always at photocopies and they are not freely available? It could even extend beyond the normal, beyond these SGBV things to forms, say you have lost a SIM card and you want to replace, and they tell you go to a photocopier, or you are reporting a case or you are doing whatever thing that requires examination and you have to go to buy these things. Is this a structural problem that we can highlight from this seminar, that members sitting or stakeholders in this particular area sitting at Makerere made this as one of the key impediments to services in aspect to probably some of these things? Is this something that we can say is one of the key things that are affecting the justice delivery in these areas, especially to the vulnerable populations? I am speaking this because I recently, I think, had from a cross-examination in a court session that involved the Katanga case. And they were questioning a police detective, asking him why he did not why he filled a form many hours later after that particular form which we were using, many hours later after probably he got briefing from a superior or whatever. And it seems the form is one tool that that is relied on almost in every step, from the legal perspective, from the court system. And if we don't say or perhaps pronounce ourselves on something like this, I know it might not be the right folder to pronounce ourselves on something like this, but we could probably make a comment that can probably the Ministry of Gender can take home, or to say, how do we follow up about something like this, to engage the different stakeholders around creating solutions for this particular form or forms. Thank you.
Thank you. I know there are other questions.
They did not clap for me.
I think, Michael, we need to wrap up this.
So I think we'll start with the representative from the Ministry of Gender, then we'll go to Julius and wrap it up. Thank you.
Thank you very much for the various questions that were raised. I want to start with the last one. I believe that should be more of mismanagement of these forms, because I know at central government level, these forms are there. DPCs are supposed to pick those forms and take them to their various stations. Sometimes others, even when they come, they don't pick them, they don't take them. A number of times I've actually picked those forms, taken them to police stations, because they are there, they're printed, they're there. And some of them, even when it's printed and taken there, because others want to misuse the forms, they decide to what? To sell it. Other times it's because even when it comes to central police at the various districts, they are not taken to the outlets at the sub-counties police station. So sometimes these people get a lot of challenges. Some of them will tell you, go to central police. How do you go about 40 kilometers to get that form and come back? That is even what? Very costly. So somehow the coordination and putting the forms in the various places is a problem. So sometimes I believe either it's negligence or sometimes mismanagement or something related to that. The issue of, yes, the reason why we always say that sometimes it's better to take the health of the person first, especially when the case is life-threatening. You cannot start by going to police and you're delayed there, and yet the person is at the verge of dying. So, but that does not stop us from getting those police forms. Because at the health center, at the hospital, history is taken, and all these are recorded. The questions that are asked, all that is documented. And when we get the police form, it's just a matter of transferring some of the information that is there in that police form. And that is the reason why we said, if the life of a person is at risk, we start with the police, with the what? With the health center. But that does not stop us from, as the person is getting the services, then we can also proceed with the other like the police getting access to that form and all that. But at least we take care of the health of that person. Yeah, that is what I'm saying. And actually we have a national GBV referral mechanism in place, where to go and all that. We have that document, it's even online. And it's not about, we are not developing it now, it's actually there, where to go in cases of violence, depending on which forms of violence. Remember, we have so many forms of violence. Some of them don't need you to even to go to the health center. Sometimes you need mediation. Like, for example, the economic violence. Some of them don't need you to. So it depends on what the case is on. And it gives us clearly the referral pathway, where to go in cases of what. And this is also cascaded at district level, because we know that at national level we have kind of a broader referral mechanism. But we want the districts cascaded to give it their own, because we want now at the district, we ask them to put what services are there, which organizations work in this area, and are there contacts you can give, so that when a person sees, he said, okay, I need this service, I can, these people work in this area, I can call them to get the service. So at the district level, what they have is more about what are those services. The referral pathway is developed with the various services that are in it. The other question is on refugees, that the number, I've not come prepared with that. I can't give you exactly the numbers of refugees, but I know if OPM is here, they can give you off head the number of refugees within the settlement and also outside the settlement. Currently, Ministry of Gender, Labor and Social Development is working closely with the OPM and UNHCR to try to see how its incidences of GBV and services that government offers is also accessed by refugees. We have GBV shelters in the various communities. And currently, because of the money that is currently with the issues of Trump and all that, money is actually disappearing. And they're saying, how do we work together? How can we have the services, link up the services that we have within our community, and refugees are able to also to access that? We are now in a we are developing, we are actually reviewing some of our documents to include refugees, especially the shelter guidelines that we have. How do refugees have access to that? What are the protocols that we need to ensure that that is done? And that is, we are working on that, and I believe that will help us go a long way, even to tell you exactly the number of cases of gender-based violence that comes from refugee settlement, and also, you know, all the issues that we are grappling with. Yeah. Is there any other thing Thank you.
Thank you very much. Yeah. So the question about why I didn't go to interview the NGOs. Yes, as you may know, when you go out to do data collection as students, we move with protocols that have been certified by the ARB. And so we tend, as students, we tend really to follow the protocols that we have presented and passed by the IRB. In my protocols, I had indicated that I would interview survivors of SGBV, not any other community leaders, for example, the Elson chairman or the cultural leaders. Then about the translators and the issue of the interpreter, I would like to inform this audience that the interpreter I had in the SGBV clinic is actually a staff of the SGBV clinic. So she was at work, and she's the translator and the interpreter in that very clinic. at the Jubilee Health Center for. Then did any of them break down? Fortunately, we didn't witness any breaking down, courtesy of the professional work and conduct of the interpreter and the translator that I had. Thank you.
Thank you, Julius. As we wrap this up, I think that was quite adequate. Though I think what the other issue was about the triangulation of sources to give you rich data and all that, but still you have to follow your protocol. And since your study was about experiences of the SGBV survivors, then you will try to maintain your focus on experiences.
Yes, Mike,
all right, yes.
Someone has a very important question. Yes, last one.
Is it to me? I hope if it's to me, no.
It isn't a question, actually. It's a response.
If it's to them, it's okay.
There's someone here who wanted to know the population of refugees in Kampala, and it isn't answered. So that's what I wanted to give. So currently in Kampala, we have 158,275 individuals as refugees registered in Kampala. I hope I have answered you.
Yes, thank you so much. We had skipped that. That really required. And when it was being raised, I thought we needed to bring out our computers and all that. Something that's really hard to, have on your hard drive in the head. But thank you for that. I'm going to invite Davidson to wrap this up and also orient us about tomorrow's program, because it's a 2-day event, right?
Thank you very much, Michael. Please give him a round of applause. Michael has done us a very wonderful job.
Can I have more before I go? Another one.
Please, another round of applause, Michael. Thank you. Michael is a very interesting gentleman. So you are most welcome. Thank you so much for really giving us your very wonderful insights. And colleagues, you will agree with me that this has been one of the, yes, please. This has been one of the most wonderful sessions. I think I should actually tell you that I learned quite a lot about this engagement. There are certain things I didn't know, but I just want to explain to you that tea is ready. We just thought we would have tea to close up our day as you go back home, but also to inform you that so tea is going to be served down. It's ready. To inform you that this is a 2-day event. Tomorrow we have very interesting sessions where, I don't know, Michael told me that I should also be part of the presenters. Fortunately, from the funders, we were able to conduct a training for some of the people who interact with the refugees, and they normally call them the fourth estate. We trained journalists in spaces that cover Chaka, Adjumani, and here in Kampala, those that report stories that you see in the media about refugees. And so tomorrow, it will be one of the things to hear what some of these journalists were highlighting as some of the key issues that emerged. So today we started a bit late because of a Monday and the traffic. I'm told UNEB has started examinations for our senior 4 candidates, so there was a bit of a mess in the morning. But we promise whatever probably did not go well in terms of our organization and arrangement, tomorrow we should be a time for you to assess whether we can do better. On behalf of the organizers, I want to really thank you so much for being a very wonderful audience, but also inform you that tomorrow we are going to be a very quite timely. I want to request you to come a bit early. It will start at around 8 exactly, and we hope to close in a bit early. So as we close day one, I want to extend my heartfelt thanks to all of you, our partners and members who came through. And we look forward to continuing some of these important conversations with you online. We have had a very wonderful live stream. This conversation is available. You can even go home and listen to it. It's on YouTube. We hope to continue the same tomorrow. And thanks again, and wish you a very pleasant evening. I can talk and talk and talk, but like I mentioned, tea is served courtesy of our dearest funders, and we want to thank you so much. You've been a very wonderful audience. If you wish, you can clap for me, but if you wish, you can clap for yourselves. Let me see if that, yeah. Thank you so much. As we continue to consolidate the gains is to consolidate in the lower section for T, right? Thank you so much. A very wonderful evening. I am told one of the